one. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. Today we have the pleasure of having Sunil Verma. He works for Karl Storz from Germany, a company based there that's been providing quality medical devices to the neurosurgical area. I'm sure they do others, but before we turn over to Sunil, let's go around the panel and introduce everybody. Hello, VJ. Could you introduce yourself?
Hello. Am I audible?
Yes,
Hello.
You're on.
Yeah, I am Dr. Vijay Parihar. I am Associate Professor Neurosurgery here in India. That is in central part of the India. And I know Sunil almost since a decade. We are working together.
Okay, welcome. Okay, let's see who's next. The other Sunil. Sunil, how you doing? Okay, go ahead, unmute. Go ahead, Sunil.
Hello, everybody. My name is Sunil. I'm from China, and currently, I'm a resident in neurosurgery here.
Okay, welcome, Sunil. Aaron, welcome. Go ahead, Aaron. I got to unmute you there. Go ahead,
yes,
Aaron.
Thank you. I'm Heron Musara. I'm a neurosurgeon in Zimbabwe.
Okay, welcome, Aaron. Great, Zimbabwe. Dr. Kazadi, say hello.
Thank you.
Okay, Naran, welcome.
Hello. Hi, this is Narayanan Janikram from India. I'm a skull-based surgeon.
Yeah, he's very active in social media, does some great shows. And
I'm very close to Mr. Sunil Verma, and I know him for past 10 years now. He's one of the fantastic speakers I've seen around the world.
Great. We look forward to seeing it. Ulrich, could you please introduce yourself? Go ahead. Go ahead, Ulrich. Oh, go ahead. Yeah, we can hear you now. Go ahead.
I'm Cameroon, currently in the Democratic Republic of Congo.
Great, Congo. Dr. Kabulo, where's Dr. Kabulo? Okay, Rakesh.
Hello everyone, I'm Dr. Rakesh Evi, final year neurosurgery resident from India. Great to see all the big names here, and I'm very eager to hear about the endoscope and its care and uses. Thank you so much.
Very good. Rakesh is a member of this team for a long time. Okay, Sunil, welcome, and could you please introduce yourself and what you do, and then it's all yours.
Thank you very much for the invitation. My name is, and I work in the department of neuro and spine with Karl Storz last 20 years, and I've been working with neuro and spine specific department since 2005, and overall with Storz for 20 years. I've been made in charge to develop India subcontinent like Nepal, Bhutan, Bangladesh, Sri Lanka, and Southeast Asia. So in all total, about 18 countries is what I see. You can see my short resume. And by education, I am a mechanical engineer with an MBA in marketing management. So prior to this, I worked 4 years in Ethicon Endoscopy. So overall, about 20 to 24 years of experience which I have, and I cover a major area in Asia. And I would like to thank Dr. I.P. Cherian for introducing me in this forum and giving us an opportunity to give some basic highlights on care maintenance and its uses. And today I'm also blessed, and it's a great honor for me to have some of my mentors and teachers, Professor Janaki Ram, skull-based surgeon from India, Dr. Vijay Parihar. They have been really instrumental in helping me to learn the subject and also promote it in Asia. So with this background, I will now directly get started on the topic. And before I get on the topic, I would like to energize ourselves by seeing a small motivational video in which the word attitude only has 8 letters, But this small word, attitude, actually brings a great difference in one's life. And if a person realizes his passion and he keeps following it, he dream it and live it, then it is said there is no age for learning. Many times people say that now I'm quite old to adapt to new technology or learn this or that. Let's see what this video wants to offer us in terms of motivation, which says keep learning all the time.
At the age of 5, his father died. At the age of 16, he quit school. At age 17, he had already
Sorry to interrupt, Mr. Sunil. There is an audio problem from your end. We are not able to hear you properly.
between ages 18 and 22, he was
Can you hear now? Can you? When I
Yeah, now it's better. Now it's better.
working as a railroad conductor and
Could you hear it?
Yeah, now it's better. Yeah, carry on.
Okay.
at the age of 5, his father died. At the age of 16, he quit school. At age 17, he had already lost
You need to share the screen, Sunil. You're not sharing the screen.
Between ages 18 and 20.
Yeah, just share the screen. Share that video. Maybe start it again. Okay, yeah, just share and then pick the video. Okay, did you click the share button?
I'm looking for that.
Yeah, at the bottom there's a share button, yeah. Like you did before.
I'm not able to see it.
That's okay, there's no hurry. The first step is to click on the share button. Have you clicked on the share button?
Yeah, I'm not able to.
Yeah, click on the share button and then find the video. Just like you did before.
Okay, yeah. Okay, I've clicked the share now.
Okay. Okay, yep, you're sharing. Okay.
Okay. There we go.
Okay, there you go.
At the age of 5, his father. Age of 16, he quit school.
Can you hear the audio?
17,
Yes.
he had already lost 4 jobs. At age 18, he got married. Between ages 18 and 22, he was working as a railroad conductor and failed. He joined the army and washed out there. He applied for law school. He was rejected. He became an insurance salesman and failed again. At age 19, he became a father. At age 20, his wife left him and took their baby daughter. He became a cook and dishwasher in a small cafe. He failed in an attempt to kidnap his own daughter, and eventually he convinced his wife to return home. At the age 65, he retired. On the first day of retirement, he received a check from the government of $105. He felt that the government was saying that he would not provide for himself. He decided to commit suicide. It was not worth living anymore. He had failed so much. He sat under a tree writing his will, but instead he wrote what he would have accomplished with his life. He realized that there was much more that he had not done. There was one thing he could do better than anyone he knew, and that was how to cook. So he borrowed $87 against his check and bought and fried up some chicken using his recipe. And he went door to door to sell them to his neighbors in Kentucky. Remember, at the age of 65, he was ready to commit suicide. But at the age of 88, Colonel Sanders, founder of Kentucky Fried Chicken Empire, was a billionaire. start all over again. Most importantly, it's all about your attitude. Never give up, no matter how hard it gets. You have what it takes to be successful. Go for it and make a difference.
So with this motivational video, I'll get on to the. Is my audio clear now?
Yes, yes, it is. It's very good.
Okay. So if you look at STORE's network, in fact, every week there is a transfer of.
Sorry to interrupt. There is a audio problem again.
You don't hear the audio directly?
The volume is low. Volume is too low.
Can you hear me now?
Yes. Yeah.
Okay.
Yeah, now it's clear. Now it's clear.
Okay, so I'll remove this ear plug. I think that is better.
Yeah, that's better sound. Yeah.
Okay, because yesterday I was using this on a test file. Okay, now every week there is a transfer of knowledge. STORS is known for training and education. It is very important for the resident and young doctors to come and attend hands-on cadaver dissection training program, which are hosted almost every week, every month around some corner of the world. And I will now introduce you to the latest fellowship training program in brain and spine in one of the top training institute called IRCAD Taiwan. They have a world-class facility where you get access to fresh frozen cadavers, and 80% of the time you are practicing hands-on and 20% is only lecture. So this new design starts from 23rd to 29th of September, and it is going to cover the entire spectrum of skull base, 360-degree skull base and spine surgery. You will get started on the first day. You can see microscopy, then it comes keyhole surgery, then endoscopy, skull base, then on the fifth day, it will have ventriculoscopy, microvascular decompression. I would be covering half-day ventriculoscopy. You can see my name here, and both rigid and flexible. Then we start with a transforaminoscopy, where you can do all types of lesion, right from T12L1 to L5S1, from central to paracentral, foraminal to extraforaminal in an awake and aware patient. And this is called stitchless endoscopic lumbar discectomy and root decompression. Then you get down to EasyGo 2. That's another technology for interlaminar approach, which Dr. Vijay Pariyar is a faculty there, and he would be talking about this technology, how he uses in neurosurgery and also for the spine surgery. Then we will talk about 3D endoscopy, interlaminar approaches, and we'll also talk about cervical, thoracic, and lumbar. So it's a very exhaustive course, 1 week, and those who are interested must come forward to utilize the time and learn over here. Now, we are also doing some fellowship program with Dr. Vijay Pariyar, who's also connected here. This is his website. This is a very good program which was started almost about 7-8 years back. It's caught up quite well attention. It's a short-term and long-term fellowship training program. You can see a 5 days training program where you get hands-on on the cadaver. You also go in the OR and see different types of endoscopic surgery for brain and spine. And it is quite well accepted now, and one must register earlier so that you get a place here. Then we also started a special training program in Mumbai. This is the Hollywood area, the Bollywood area of India with this website. And in this, if you see, there is a special brain model which has been developed by Dr. Depujari by using the mesentery and the omentum of the pigs, and with connecting in the pump, you have the prepontine cistern area, the barrel artery, the oculomotor nerve, the abducens nerve, and the thick arachnoid strands. So when the pump pulsates, you get a feel as if you are working on the live patient, because it is difficult to practice on the cadaver as the ventricles gets collapsed. So the next program which is coming up is from 12 to 14. I am also one of the faculty. I cover some part over there, and there'll be hands-on training program. So this is another center which you can look. Now, this is another program coming up from my teacher, my mentor, Dr. Janaki Ram, who's quite well known across the globe. And this is a fantastic program where you practice 2 days on the fresh frozen cadaver. So Dr. Janaki Ram would be demonstrating all the steps in the sagittal, the coronal plane, in skull base, and next day on the 16 people can practice. So this is open now for registration, and kindly all the resident young doctors who make use of this. With this, stores also give and provide lot of clinical tools which are very essential, and these are given free of charge and free of cost. Why it is important to have these books, and one must learn through this, is to understand the endoscopic perspective of the anatomy. I have all these books, and you can always approach the stores reps to get this, because if I now ask a question to the residents, can everybody speak ABCD up to Z? The answer is yes, everybody can speak without thinking, because these alphabets have gone in the frontal lobe and hippocampus from the childhood. We have memorized it like a prayer. But let's see how many of us can speak Z, Y, V, X, W. I think it will be very rare if somebody can speak, because the anatomy is the same. The issue today is when we put an endoscope, you are looking the anatomy in a circular manner, the image in a circular fashion, and most of the time the endoscopic perspective of the anatomy is lost. So it is important for the young doctors resident to recaptivate on the endoscopic perspective of the anatomy, and there are fantastic books there. Also, books have come from Dr. Janaki Ram. I'll be showing his book also, and the earlier version also is there. So these are the very good books, and at the end of the books, you find the surgical technique demonstrated and the kind of instruments required and a recommended set. So these are very good books. I just gave a glimpse for a neurosurgery. Is the voice all right? Everybody can hear?
Yes.
Okay. So let me know in case the voice is not clear, because now I'm not using earplug. So you can see Dr. Janaki Ram book is also there. This was a earlier version. Now we have more books, and there are plenty of the books, around 20 books we have. Now also in spine surgery, there are numerous books. This is one of the books which I'm going to show is from Professor Otel. It also has a similar module that we start with the instruments, the anatomy, the surgical procedure step by step, the endoscopic perspective of the anatomy, do's and don'ts, and how to avoid complications, etc., with a recommended set. So books are very, very essential for all the young doctors to go through it, and they are provided free of charge. Now, neuroendoscopes are classified as rigid endoscopes or flexible endoscopes. This is the basic classification. In the rigid endoscope, you have a rigid rod lens system where the rigid rod lens are engraved in the shaft, followed by a light transmission bundle engraved with a camera head, and you get a image on the video monitor. And the image is definitely far, far superior than the flexible. But I will introduce you a new flexible technology. Also, the rigid endoscopes are classified as diagnostic, where there is no working channel. So this is only used for visualization purpose. However, if you would like to do a therapeutic procedure, you will have to use a scope which has a inbuilt working channel and some channel for inflow and outflow of the fluid. Mostly in neuroendoscopy, surgeons prefer to use a ring-lactate warm solution approximately close to the human body temperature to avoid hypothermia, because the isotonic composition of ring-lactate RL is very close to the cerebrospinal fluid. And now the new technology has also evolved where you have a round knob on the diagnostic scope, which is called an endochameleon scope, And by rotating this, you can have different angles of view, starting with 15 degree to 30 degree to 45 and 90 degree. So one scope can give you variable angle of view. This is a fantastic scope to do your skull base, right from planum sudale down up to the clivus, foramen magnum, and the base of the C2 vertebra you can see. And in the coronal plane, you can do a transethmoid, transpterygoid, infratemporal fossa up to jugular foramen. So this is the technology. If we look at the flexible endoscope, where you see two, one, the black one, which is still existing. Earlier, the visualization of these scopes were inferior to the rigid endoscope because it has a fiber technology. There are here like fiber benders which are engraved here, and surgeons were trying to do aqueductoplasty, go through the aqueduct of Selves, open foramen magendi, foramen luschka, or posterior fossa tumors, etc. And vision was not very clear. But now you see this new technology. This is called chip on technology endoscope. There are no fiber bundles inside this cable. There is a direct CCD, which is called a charge couple device at the tip, and we have shortened the length. It is a working length of 35 centimeter, which is good enough to do any cranial procedure, and you can use it for any type of lesion in the brain, especially when you do ventriculoscopy. The tumors around the aqueduct of Selves, or seeing around the corner, or doing posterior fossa tumor like foramen magendi, foramen luschka tumors, or any type of tumors you want to see, have a look at this video. Can you see this video which I am playing? Professor John, can you see the video?
Yes, we can see that.
Okay, so you see the clarity. So today the technology has changed. So this is the new technology from stores called the video neuroendoscope. Sometimes you can even use into the foraminoscope and push it in the epidural space to see if there is any loose fragment left, up migrated or down migrated, if you are doing a targeted fragmentectomy in spine surgery. So you can use it in multiple applications. So this is the latest, and the visualization is very good. We have a user, Dr. Subodh Raju in India, who's extensively using it for posterior fossa tumors. And this is what I wanted to show. Moving forward, we have also developed a 3D endoscope. We have Dr. Janakiram here, who has used it many times, and probably we can also learn a lot from his experience. And combining a 3D endoscope along with 2D, there is a direct button. You can switch between 3D and 2D whenever a surgeon is having difficulty to see a particular structure or the depth perception at which it is, which I will come a little later on. You can use this endoscope, and whenever you want a 2D image, there is a button. You can press the button and change it to 2D. So this is what is there in the latest technology. This is being offered in terms of a 0-degree scope, a 30-degree, and 45 degrees also on the way. Now, I'll go on to the main topic, which is called care and maintenance of endoscopy. And there is an old proverb even for our human life, that prevention is better than cure, which is also true for the technology. If we learn the right way of handling the equipment, especially with the paramedical staff who handle most of the time, then the life expectancy goes very high and you have less chances of breakdown, and you can save on cost. As surgeons look after their patients with utmost care and look into very minute details, right from the patient coming in the ward and after the surgery going out, if we have the same pattern of looking into the equipment that is brought by the hospital, I am sure the life expectancy of all the components which are together give you an endoscopic image can definitely be enhanced. And we are going to look into this one by one, that how can we enhance the life expectancy of your equipment working in the theater. We shall also discuss briefly assembly and disassembly of the equipment through video, so that it is very clear how step by step the video is the equipment is assembled and how it is used in a surgical procedure. Now, it is very important for the surgeon, in fact, for the paramedical staff, to give a sterile instrument and follow an aseptic technique. There is always a saying in medical that the lady is either pregnant or she is not pregnant. A lady cannot be 80% pregnant. So the instrument is either sterile or not sterile. So we will now look at how step by step in a surgical procedure, the equipment is assembled and sterilization takes place. Now, if you see this adapter, which I am going to highlight in the form of the video, looks a very small component and many times it is not procured for whatever the reason may be. This creates a great value to follow aseptic technique. When you put the camera cover, disposable camera cover, which I will now go on to the video so that it makes more sense that how this is assembled, and we will also look into a very good surgical video, a standard video, how to perform an endoscopic third ventriculostomy, and in that I'll be explaining this. So here I go on the video now. So have a look.
The 52-year-old female patient presented with headaches and an increasing sensation of pressure in the head. This sensation of pressure increased in particular when the patient lay down. The axial MR images show a clear enlargement of the lateral ventricles and the third ventricle of the brain. In the sagittal MRI, constriction of the proximal aqueductal area, as well as clear bulging of the floor of the third ventricle of the brain into the prepontine system can be seen. The patient is placed in the supine position with the head antiflexed and straight. The ideal point of entry is firstly determined and the relevant area shaved. The best point of entry for ventriculostomy is approximately 1 centimeter in front of the right coronal suture, approximately 2 to 3 centimeters lateral of the midline. Following disinfection, the patient is covered with sterile drapes and the pneumatic holding arm is covered with a sterile sheet. The skin incision is approximately 3 centimeters in length and runs parallel to the sagittal suture. Following the skin incision, the periosteum is reflected and smaller bleeding arteries in the galea are closed by means of bipolar coagulation. At the lower pole of the skin incision, the coronal suture can be seen. The localization of the planned burr hole is shown. A 1 centimeter large burr hole is then created in front of the coronal suture. The HD video camera is connected to a sterile optical adapter.
Now this is a very important optical style adapter because there are 2 types of camera heads. This particular camera head which a surgeon is holding is actually a non-autoclavable or non-autoclavable camera head. There is another variety which is an autoclavable camera head which can be autoclave along with the cable at 134 degrees centigrade, 5 to 8 minutes, 3 atmospheric pressure. So if you use that autoclavable, you need not use the adapter. Now why we are using it, the video will tell you.
Which allows the telescopes to be changed under sterile conditions during the operation.
Because the inner portion of the camera head is unsterile. If we do not use the adapter, then change the endoscope, it is not going to follow a aseptic technique when you change the scopes between a 0 degree, 30 degree and 45 degree or from diagnostic to therapeutic scope.
The sterile cover is then pulled over the camera to avoid having to sterilize the camera, which reduces its service life. The sterile sheet is fixed behind the adapter using adhesive tape to prevent it from slipping.
Now, this adapter was autoclaved, so now the inner portion is absolutely sterile. So you can now change any types of scope. If we were not using this adapter, directly putting the scope between 0, 30 or any angle of view, it will never follow aseptic technique. Few years back, I spoke to one of my doctor friends in India. He landed up with consecutive 2 cases of infection. Probably this adapter was not there and the paramedical staff was not aware that an adapter like this was to be used to follow aseptic technique. So this reduced infection during the surgery. And let's see further. Also, this sterile cover, many times in some small hospitals, they don't get these covers easily available. They use a cloth. So the sterile cloth is draped over this. The disadvantage is you cannot see. To get a true endoscopic anatomy image, the camera head buttons always have to face upwards. So if you use a non-transparent piece of cloth or any other thing over the camera head, you will never be able to know whether you are in the correct anatomical position or not. Now, the first ring is the focus. The second one is the power focus zoom lens. It is important to understand its functions. It has great advantage in the surgery. What is the meaning of power focus zoom lens? Suppose you are drilling, close to the carotid canal. The surgeon wants to come and see. Like many times I see Janki Ram sir is always drilling on the carotid canal to do carotid transpositioning, etc. So instead of coming too close, and when you are drilling, the water is going to speckle back on your scope and cause a little fogging, you can always use the zoom. In a power focus zoom lens, if the focal length is defined f25 to 50 mm, which means you can move the image of your video monitor close to your eyes by 2.5 centimeters without readjusting the focus. So hence a power focus zoom lens means once the camera is under focus, whether you increase the zoom or decrease the zoom, you will still be in focus. So this has great advantage when you are working close to the vascular area and avascular area. You can zoom in and zoom out. Many people do not use this, but this has great advantage in the surgery.
Using the sterile optical adapter, the ventricular scope is connected to the camera.
Always check by pulling it back whether it has got totally engraved in the camera head or not, because sometimes it is not completely engraved. When you really go, it can just fall down on the sterile table. Now, we have color coded the endoscope. The green color over here marks 0 degree. Why it is important for paramedical staff and doctors to know these color code which have been standardized? Because in any endoscopic procedure, the surgeon prefer to have very less light in the OT. So the top lights are usually dimmed off so that the monitor can give you a sharper image, and a green color refers the 0 degree. However, in a therapeutic scope, because it has working channel, we have changed a 0 degree to 6 degree. Why we have done that? Because when the surgeon is putting an instrument, the issue in an endoscopic image is you are working in 2 dimension. I mean, you are seeing in 3D but working in 2D. So when you are working in 2D, you are not able to get a depth perception. So when you insert the instrument, which is just coming at the tip, the surgeon has to wait literally 1 centimeter, the instrument come out, and then you can see the instrument has come out. So that depth perception is missing. So it is important to have depth perception. So we moved it to 6 degrees. So moment the instrument comes out, it gives you a further extra angle of 6 degree laterally, and you can see your instrument has come out. So that's the advantage. So seeing in 2D and working in 3D.
Now fixed to the screw adapter, and the automatic white balance is performed after the light source is turned on.
Now next question comes to us, that what is this white balancing and why should we do that? Please understand that camera does not understand colors. It is just a machine, it's a tool, it's a equipment. So in order to appreciate true natural tissue colors, we have to create a white background in the memory of the camera so that true natural tissue colors can be appreciated. So when you do a white balancing, make sure you take absolutely white gauze piece. The entire surface area is completely covered white. It should not happen that you are using a angled scope like 30° and half portion is white gauze piece and half portion is the sterile uh, cover drapes which are there. That then it will be difficult to sense the natural tissue color. And while doing the surgery, you will find that your blood is looking like tomato ketchup sauce or some other brand. Now the next question which comes is that shall we do a white balancing every time we change from a 0° to 30 or an angle scope or from a diagnostic to therapeutic scope? Many people I see, they are redoing the white balance. Please understand there is no need to do white balance once you have done at the beginning of the surgery, because the colors are appreciated in terms of light source. The xenon light source, which is now very well used and accepted, it is giving you a color temperature of more than 6000 Kelvin, which is close to the color temperature of the sun. Before that, there were metal halides which has phased out. They used to give a color temperature of about 5400 Kelvin, and you could see a little bluish tinge in the endoscopic image. Halogen light source are still there. Some of the ENTs are for basic functional endoscopic sinus surgery or basic laparoscopy, they use it. And the color temperature of halogen light source is about 3400 Kelvin, and that's the reason you have a yellowish tinge. So once you do the white balance, if you are using the same light source, the same xenon light source, and not changing the light source between a xenon to metal halide or a halogen, there is no need to do white balancing, and you can save a lot of anesthesia time, which is very, very important for the operating surgeon. And many times surgeons are redoing the white balance, and in a hurry, they take an angle scope and the whole surface is not covered with white, and it senses the color of the sterile drape, and you do not get a very good color. Now, we move further and I explain.
For the white balance. The focus and zoom are set using the small wheels on the camera head. After bipolar coagulation of the dura, a cross-shaped dura incision is made. This is followed by bipolar coagulation of the cortex. Once the endoscope sheath has been fixed to the pneumatic holding gun, the locking mechanism is locked. The right
Now, when a surgeon is using a ventricle puncture needle, sometimes he goes directly. If it's a case of a high pressure hydrocephalus, after going inside, you should put your thumb near the lower lock and gradually allow the CSF to come out. Otherwise, in a high pressure hydrocephalus, suddenly the cerebrospinal fluid comes out like a jet. It can lead to brain herniation. It is also important for the surgeon to ensure 100% hemostasis at the cortex. Why he needs to do that? Because once your sheath and the endoscope go inside, if there is not 100% hemostasis achieved at the cortex, gradually drop by drop, the blood comes in the lateral ventricle and your image starts getting diminishing and you look little light reddish color and you don't get a very good clarity. Number two, while a surgeon is making a burr hole, the paramedical staff can help in connecting your camera, connecting the light cable, connecting the cautery cable, doing a white balance, and save 10 minutes of anesthesia time. It is important to also connect the endoscopic monopolar and bipolar electrodes with cautery, because in a standard ETV, you may not use a bipolar electrode, but God forbidden, if there is an emergency or something, if cables are not connected, it can lead to a disastrous condition, because in neuroendoscopy, we say it is a highly precision surgery. It's like training the pilots, and pilots never ever come back on the planet Earth and tell what went wrong in the accident. It's only the taxi driver who complained that this guy was driving fast, so he hit me first. So it's a very precision surgery. It's like training the pilots, and every details have to be followed during the surgery.
Anterior horn is firstly punctured with the Scott cannula in order to confirm the correct trajectory. CSF sample is taken for laboratory and, if necessary, microbiological examinations. After the Scott cannula has been removed, the endoscope sheath is immediately advanced.
Now, this angle is decided by the surgeon after taking the external aortic canal, the mid-pepper line, and the third plane coinciding this. It is very important to mark and understand these centimeters marking, 1 centimeter, 2, 3, 4. Usually, in most of the cases, a surgeon reaches the lateral ventricle 5 to 6 centimeters. So it's important to ensure, either put an index finger or ask somebody to look how deep you have gone. One time I saw a surgeon had asked the paramedical staff, how deep he is, and the medical staff said, yeah, around 6 centimeters. It was already 8.5, and there was a trauma to the lamina terminalis. So this centimeter marking is of utmost importance for the surgeon.
Into the anterior horn of the right lateral ventricle of the brain using the obturator in order to prevent CSF loss via the puncture channel. After releasing the locking mechanism, the obturator is removed and the ventricular scope inserted.
Now, before you enter, either you check the anatomy on some reading material, your orientation is correct or not, or you check these buttons, always facing upwards, 12 o'clock position to the roof. You get a correct anatomy of the ventricle. Your orientation is correct.
The irrigation tube is then fixed to the irrigation channel.
So you can connect your RL, ringal actin.
It looks directly onto the foramen of Monroe and can recognize the big veins and the co-rod plexus. To achieve a better overview of the ventricle anatomy, the ventricular scope is removed and replaced with endoscopes with different angles of view. The first inspection is performed with a 30-degree endoscope. To exchange the endoscope, the light cable is disconnected from the ventricular scope, and the ventricular scope is released from the camera via the optical.
Now you see he's changing between the therapeutic and a 30-degree diagnostic. That's why this adapter is going to help. Otherwise, if the scope, this adapter was not there, would have gone on the table and then coming back, it would have made it unsterile. So that's the advantage of the adapter. Now, when you change, make sure that somebody is standing on the video monitor trolley and reduce the light source. There is a button which you can put on the standby mode, because if this light source is not reduced, it's a xenon high intensity light source. It can come on the surgeon's eyes and make him uncomfortable, or even if it is kept on the sterile drape, it can burn it off. So now we are connecting with the 30-degree to have a complete diagnostic ventriculoscopy.
The 30-degree endoscope is fixed using the optical adapter and the light cable connected. The 30-degree endoscope.
Okay, in any angle scope, the red color marks 30-degree, green color marks 0-degree, and the yellow color is 70-degree, black color is 45-degree. If the light cable is now pointing down, in any angle scope, the surgeon is looking upwards. So if the light cable is going down at 6 o'clock, surgeon is looking 12 o'clock. If the light cable is moved at 3 o'clock, surgeon is looking at 9 o'clock. So this is how you will see. So once you open the floor of third ventricle and you get into prepontine cistern area and you would like to see your basilar artery, you should then use a 30-degree and push the light cable.
Now advanced via the endoscope sheath.
इसलिए फोटो छोटी दिखा रहे हैं, ये जो जहाँ जहाँ ऑपरेशन
By turning the endoscope on the light cable and maintaining a constant camera position, one gets an all-round view of the right lateral ventricle of the brain and can look backward into the cellar media. The 30-degree endoscope is then advanced through the foramen of Monroe into the third ventricle of the brain. One can see the floor of the third ventricle with the infundibular recess, optic chiasm, and the terminal lamina. In the third ventricle too, the endoscope is rotated through 360 degrees to allow the resection of the third ventricle to be visualized. The entry to the aqueduct can be seen at the bottom edge of the image. The 45-degree endoscope, which can also be rotated through 360 degrees.
Now we connect another angle scope 45 degree. We'll have much more lateral view compared to the 30-degree scope.
As an even more comprehensive organ.
Please note the way he's rotating the light cable. Light cable should be rotated from 0 degree here, 180 degree up, and 0 degree here, 180 degree here. Do not twist it completely. So move from one side up here and again opposite side to have a complete view, because sometimes the surgeon goes inside when the anatomy is distorted in a multi-located, multi-separated, infected hydrocephalus cases. A surgeon is not able to see the foramina Monroe, and then he cannot proceed. Although we know that we have to follow the choroidal fissure which leads us to the foramina Monroe, so at times you have to use an angle scope diagnostic to have a complete view of the ventricles.
It provides a view along the choroid plexus to the trigone. The 45-degree endoscope is then advanced through the foramen of Monroe into the third ventricle. Now one can see the fornix on the opposite side, the anterior commissure, the optic chiasm, and above-lying terminal lamina, through which the anterior cerebral arteries shimmer. On rotating the 45-degree endoscope through 180 rear, one can see the entry to the aqueduct with the above-lying posterior commissure, the pineal recess, the habengular commissure, as well as the roof of the third ventricle with the choroid plexus. Following inspection using the angled endoscopes, the ventricular scope is used again, and the endoscope sheath is inserted through the foramen of Monroe into the third ventricle.
Now, this is a very good technical point. Sometimes when you are doing cases, you may not get large enough foramina Monroe. That means the foramina Monroe is not large enough to accommodate your neuroendoscopy sheath. And if you are not sure that it can pass through the foramina Monroe without traumatizing the walls of the fornix here, then there is a lower lock, you open it and you withdraw the endoscope inside the sheath by 1 centimeter. And by doing this, you can now clearly see the edges of the neuroendoscopy sheath. Then together you travel and see whether you can, you come close to the foramina Monroe and you see whether the edges of the sheath can easily pass without traumatizing or rubbing through this. In case you feel that you cannot do it, then you change it to a smaller diameter sheath, the little LOTA sheath, and proceed with the surgery. There is no point in pushing the endoscope through this and traumatizing the walls of the fornix at the end of the surgery. and just doing a third ventriculostomy.
Under endoscopic visual control. It is very important here that the endoscope is retracted into the endoscope sheath in order to visually control the edges of the sheath and so prevent injury.
Suppose you are not able to go and there is no smaller sheath, then the other possibility is in the set we supply you a 2 millimeter endoscope. You can lock the neuroendoscopy sheath in the holder, whether you use mechanical or a Mitaka arm. Professor I.P. Cherian from Nepal uses the Mitaka arm. It's like a robotic arm. Even in this video, you saw that. Then you remove the neuroendoscope, and thus just the sheath is now in the lateral ventricle. Now you insert a 2 millimeter endoscope and you hook your camera head behind the eyepiece of the 2 millimeter. And from the side, you can put a forceps, open the floor of the third ventricle, and then get into the prepontine cistern area to have a look that you have opened the second membrane called the Lilliquist membrane. So these are the two ways. Or you use, third option is a visual obturator, which is about 4 millimeter in diameter with the 2 millimeter endoscope, and you can pass through the foramina mundi. So these are three options.
Veins in the area of the foramen of Monroe. The floor of the third ventricle of the brain with infundibular recess.
It's very important to open the floor of the third ventricle. If you draw an imaginary triangle taking the apex of the mammillary body, the center part of one mammillary body and the other, and draw a line from the infundibular recess, this triangle in the center, it is said it's usually very safe. However, if the floor of the third ventricle is very tough, non-transparent, non-translucent, could be very thick, and if somebody is at the beginning of his career not very well experienced, then it is better to use a probe, just palpate around this area on the higher side, feel the bone, the clivus, and keep coming down, just posterior to it. You will see that, oh, there is some space, there is no hardening backside. That would be a very, very safe area to open the floor of the third ventricle. And dithermy should be avoided as much as possible because it causes unnecessary fibrosis, and it becomes very difficult to enlarge the floor of the third ventricle, the stoma opening.
Mammillary bodies is then visualized. All the
Now, this was an instrument called a reverse grasper. I will just explain this.
instruments feature a length marking which shows when the tip of the instrument emerges from the working channel.
Now what we have done is, these length of the instrument are usually 30 centimeter long. When a surgeon is putting the instrument, first of all, we have given you a funnel shape, because when you try to aim your instrument, if this opening is small, it is not funnel shape, then the instrument is dangling here and there, some are semi-rigid. So the surgeon has to keep looking when his instrument is going to be out in the ventricle through the neuroendoscope sheath, because you are seeing in 2D. The endoscopic image is a 2D image on the monitor. You are seeing in 2D and you are working in 3 dimension. So we have now put a black marking. So watch out this black marking. Moment it reaches the tip of the circumference of this funnel, that means your instrument is just now exactly at the tip of the neuroendoscopic sheath, and further advancement of the instrument will take out your instrument. Why this has been given, and it is so vital, because if a surgeon is tomorrow putting a scissor, a single action or a double action, and you are trying to do a marsupialization of arachnoid cysts, etc., then the scissor could be a little risky. So this marking helps for that purpose.
Initial perforation of the ventricle floor is done.
Now, if you see this instrument, it is called a reverse grasper, and we call it a third ventriculostomy forceps. Earlier surgeons were using a normal graspers or biopsies, and when you try to go in, the floor of the third ventricle is moving. Sometimes you go too deep, and unnecessarily there are high chances of hitting the basal cisterns there. So here these grooves, you can just entangle it at the first level, and the membrane gets stuck here, it doesn't slip, and then you open it and go away from the prepontine cistern to make a safe opening or stoma. While doing this, you try to come out away from the prepontine cistern area and then use a 3 French Fogarty catheter. Now I'll explain this special 3 French Fogarty catheter from STOS. We have first of all reduced the length because it is said the shorter the length of the instrument, better is the hand-eye coordination skill. Second is it's a 3 French Fogarty catheter. So the tip and the place, the tip of the Fogarty catheter and the place where the balloon inflate, this distance is now very, very small, hardly 2-3 millimeters. So you actually travel very less distance inside the prepontine cistern area, and it is very quite safe. So there are less chances of hitting the basal system. There are 2 ways of opening the floor of the third ventricle. Either you use air inflation or you can use the saline inflation. I have seen most of the time people prefer a saline inflation because uniformly it expands and it contracts. Secondly, this special Fogarty catheter which STOS get it made outside is to help you for a safe surgery. Instead of opening in a circular fashion first, it opens little cylindrical so that if the floor of the third ventricle is moving, it does not slip out. Watch out this now.
The ventriculostomy opening is expanded by inflating the balloon of a 3 French Fogarty catheter filled with saline solution. Due to the configuration of the balloon, it needs to be inflated several times in order to achieve an adequate ventriculoscopy opening.
You see, while inflating, he is trying to go away from the prepontine cistern, means coming out. And when you inflate, there are some bleeding edges. In neuroendoscopy, ventriculoscopy, 90% of the time you can manage bleeding management are done by using the irrigation method. So continuous irrigation with RL helps you, and these bleeding edges can obviously be coagulated, or you can have hemostasis by inflating the balloon and keeping it there for half a minute or 1 minute. So automatically hemostasis is achieved by tampering effect,
which should be around 4 millimeters in diameter.
And 3 French is pretty safe. You will not land up opening the stoma or the opening beyond 6 to 7 mm with the 3 French. So it's a pretty safe 3 French Fogarty catheter. Several inflation deflation should be done to achieve that. And obviously one must ensure to open the Lilliquist membrane. And please note, in a as per LOA classification by Professor Shizoi of Japan, LOA, long-standing hydrocephalus in ventriculomegaly patient, the Lilliquist membrane is so thinned out that it looks there is no second Lilliquist membrane, and you are just able to see all the structures in the prepontine cistern area.
Minor hemorrhage from the edge of the ventriculostomy stops after a brief irrigation period. After performing the ventriculostomy, the ventriculoscope is removed and the 30-degree endoscope is inserted for inspection of the prepontine cistern.
Now you see this is a red color on the adapter. It means his surgeon is using a 30-degree scope. Always your camera head button should be facing on the top. Light cable has moved 12 o'clock position. That means the surgeon is now going to see the view at 6 o'clock. Why has he made this? Surgeon probably wants to have a look at the basilar artery. In some cases, you can see the ocular motor nerve very clearly, and even the abducen nerve going in the Develos canal.
One can identify the basilar artery with its branches, which indicates that sufficient communication to the subarachnoid space has been created. Following successful ventriculostomy, the endoscope sheath is pulled out of the foramen of Monroe under end.
Now, sometimes the surgeon is operating, he gets an air bubbles coming in. You can always take a freehand RL saline shots with the syringe. The air bubbles will vanish. And once you finish the surgery, you had a look, everything is opened up fine. You keep irrigating and come so that no air bubbles are staying there.
Endoscopic visual control. One can see that the plexus, fornix, and veins are undamaged.
Yeah, this is important to inspect the fornix while coming out, that nothing has happened there.
The endoscope is also removed from the cortical puncture channel under endoscopic visual control in order to be able to recognize hemorrhaging in the ependymal veins or in the cortical puncture channel. ensure a defect is sealed using Gelaspon, which is
So many times surgeon is using the bone dust and the Surgicel, etc., and to close the burr hole so that there is no subcutaneous collection.
into the burr hole. The skin incision is closed using Galea sutures and a continuous atraumatic skin suture.
So here the surgeon was using a Mitaka arm. Dr. I.P. Cherian also used back home in Nepal. Now let's see another case where the foramen of Monro is not dilated. So Stores also has technology to handle such cases with a smaller diameter sheath. And let's see a more difficult case, the next case.
The 43-year-old female patient had complained of progressively worsening headache attacks over several weeks. The MR imaging shows an obstructive hydrocephalus which is caused by a non-enhancing tumor in the area of the aqueduct. The lateral ventricles and the third ventricle are considerably expanded. In the sagittal views, one can see the bulging of the floor of the third ventricle of the brain into the prepontine cistern and the compression of the pituitary stalk as an indication of the pressure gradient between the third ventricle and the cisterns. The very narrow foramina of Monro are particularly noticeable. A right precoronal burr hole was chosen as the access point.
Now here the foramen of Monro is very small.
The foramen of Monro is relatively narrow. The endoscope sheath is advanced into the third ventricle with the help of the optical obturator. Thanks to the conical tip, the foramen is dilated without damaging the edges. By rotating the 30-degree endoscope backward, the entry to the aqueduct can be visualized, which is obstructed by gliomatous tissue. As is typical with chronic hydrocephalus, the floor of the third ventricle has thinned out.
Okay, sometimes the floor of the third ventricle looks like a lollipop. It looks very transparent, translucent. The basal cistern, the basilar artery branches looks very clear, which is a good for the surgeon, an easy case. But when the surgeon tries to push the forceps to make a small opening or a stoma, the membrane is more like a rubberish. So it just keeps going in and out. It's very hard to open it up. It slips all the time. So then the surgeon can do is, there is a curved double action scissor by Stores. You can take that scissor, feel the bone, the clivus, and because there is a back support on the bone clivus, just take the scissor, make a small nick with the curved scissor, the floor of the third ventricle will just fall down and you will get an opening there to further enlarge with Fogarty catheter.
You can see the branches of the basilar artery and on the left-hand side, the oculomotor nerve through the floor of the ventricle. The floor of the ventricle is initially perforated on the midline, exactly behind the clivus, using the deck forceps. The perforation opening is expanded by inflating the balloon of a 3 French Fogarty balloon catheter. To ensure the slow and continuous enlargement of the balloon, the latter is filled with saline solution. The balloon must be inflated in order to achieve an adequate ventriculostomy set of approximately 3 millimeters. The strong pulsing of the floor of the ventricle indicates a good CSF flow. To ensure communication with the prepontine cistern is achieved, inspection is carried out using a 30-degree endoscope. One can see the branches of the
It's very important to ensure the Liliquis membrane is always open. The thick arachnoid strands are open, Liliquis membrane open. Otherwise, it's an incomplete procedure.
The artery, and on the left-hand side, the ocular.
Yeah, so here you can see the ocular motor nerve. It's always between the SC and the PCA, the superior cerebral artery and the posterior cerebral artery. Endonasally also, when we do, we always see ocular motor nerve between these two vessels.
The endoscope with sheath is then carefully pulled out of the third ventricle. The anatomical structures in the area of the foramen are intact.
So
To
this
rule out
was
an active source of bleeding, the endoscope sheath is removed from the cortical puncture channel under visual control.
so you can see there's complete hemostasis at the cortex. Now let's see another difficult case where the arachnoid strands are very thick. Surgeon is trying to open up with the scissors. Yes, is the audio okay? Video and audio is okay?
Yes, it is. It is. Excellent.
Okay. You are enjoying the show, I believe?
Oh, it's excellent.
Okay. Now I'm going to show another case, and which is a very difficult case to open the thick arachnoid strands. This is a video of Professor Henry Schroeder from Greifswald University of Germany, and he used a scissor. But for a beginner, opening these arachnoid strands, you need a big heart. So after that I will show you the new technology, the product, which is called a guillotine knife, to make a safe opening. So let's see another more difficult case in ETV, because ETV people say I'm doing, but some cases are really quite difficult with distorted anatomy. So let's have a look at the next case.
A giant ganglioglioma in the right hemisphere was diagnosed in a 7-month-old male infant. Following unsuccessful chemotherapy, the tumor was completely resected 7 months later in 2 sittings. The post-operative course was initially uneventful. The young patient developed very well with a slight psychomotor retardation. 1.5 years after the operation, the boy presented with headaches, nausea, and vomiting. The MR imaging showed an obstructive hydrocephalus caused by aqueductal stenosis with considerable expansion of the lateral ventricles and the third ventricle. A ventriculostomy was then performed in another hospital, and due to ventriculostomy closure, further reventriculostomies were carried out 14 days and 4 weeks after the initial ventriculostomy. When the boy presented at our hospital, again considerable expansion of the ventricles of the brain and reclosure of the ventriculostomy with absence of flow signal in the area of the ventriculostoma were diagnosed. Given the clear closure of the aqueduct with a verified obstructive hydrocephalus, reventriculostomy was indicated. Access is created via the right lateral ventricle. One can see that the ventriculostomy is completely closed by a gliotic membrane. To visualize the entry to the aqueduct, the 30-degree endoscope is rotated dorsally through 180 degrees. The inspection shows that the entry to the aqueduct is completely closed. The compact floor of the third ventricle is perforated using deck forceps, and the perforation is spread open. The perforation opening is then expanded by inflating the balloon of a 3 French Fogarty catheter. The endoscopic inspection of the
Now you see they are very thick arachnoid strands. Earlier we did not have that special guillotine knife when this video was made, and after this surgery we were told that you have to come with something different so that it can be opened. The surgeon is using a scissor, which is quite risky. Let's see how he's opening it up.
Contact system shows numerous arachnoidal adhesions which prevent the flow of CSF. The compact membranes are transected right next to the clivus using the microscissors in order to avoid injuring the small basilar branches. All the membranes are transected step by step until the free prepontine subarachnoidal space is reached. The endoscopic inspection.
Now if you see this white structure here, this is the abducen nerve, the 6th cranial nerve going in the Develos canal. So in some cases you can see the abducen nerve also very clearly.
With the 0-degree endoscope
shows
the free passage of CSF to the free subarachnoidal space in which one can recognize the entry of the abducent nerve into the Develos canal. With the 30-degree endoscope, one can see the lower cranial nerve group on the left and the abducent nerve in the middle. The final inspection shows the free passage of CSF through all arachnoidal membranes and the wide-open ventriculostomy. The endoscope is removed from the third ventricle under visual control. The structures in the area of the foramen and Monroe are undamaged. To make sure that there is no hemorrhaging in the lateral ventricle and in the cortical puncture channel, the endoscope is also removed under visual control.
Now, if you have an infected case, TBM, tuberculosis meningitis, etc., when you put the endoscope, you have a very shabby image, a little yellowish in color, and surgeon has difficulty visualizing the structures. So keep giving a lavage with the RL continuous irrigation one side and the other outlet open. Gradually, it will, that yellowish infected fluid comes out and you get a better image, then proceed. Now I have a huge collection of videos. I take it from many doctors. Dr. Narayan Jankiram has given me a huge collection. I have from other doctors like Vijay Pariyar. Since today the topic is also on care maintenance, so my next lectures in I'll be showing more videos. So I will now go on to the maintenance part because then I have more videos to show on skull base also and how we prevent this. Now, I think I gave you a fairly good idea that how these products were used. This product which is used here is actually a bipolar. It looks like a monopolar. So many times people feel that, oh, this looks like a monopolar. There is a white tip here. I will show you the procedure. It is a ceramic insulation. Now, the property of ceramic is it is a very high heat resistant. So when the surgeon wants to do point coagulation, he is able to achieve that and very less minimal lateral thermal damage to the adjacent tissue, leaving a very less necrotic tissue behind. So these are the equipment which was used, and we will now look what is the anatomy. I mean, surgeons have been using endoscope for quite some time, which is good, but sometimes it's good to know the anatomy, how this endoscope is made. And I will share a short video how it is prepared, but in nutshell, there are two shaft system, one inside the another one, and inside the inner shaft we put a series of rod lenses, and then between the shaft there is some space left where we put hair like fiber bundles, and finally these light transmission hair like fiber bundles, which is white in color, comes and it is engraved at the light cable attachment. And the scopes are of different diameters depending which area you're using in laparoscopy, gynecology, and the smallest diameter endoscope that we have made is a shunt scope, which is a 1 millimeter diameter, and a laparoscope 10 millimeter. Of course, that laparoscope 10 millimeter can also be used for an endoscopic anterior thoracic spinal fusion under single lung ventilation. Also, we'll cover this topic next time. So this is how it is made. And whenever a light is being transmitted from one medium to another medium, we always get in physics. Yes?
I'm sorry, I think there was a little...
Any questions?
No, that's okay. I'm sorry to disturb you.
Okay, so whenever the light is transmitting from one medium to another medium, there is always a light transmission loss. And we say in STOS product, there's a very minimal loss, because what we do is we put a very high quality of refractive index coating on these rigid rod lenses which are there. And between the rod lenses, we put what is called metal spacers, so that if there is a mechanical thrust, it accidentally hits the sterile trolley or falls a little bit here and there, the endoscope is protected. If you see the tip lens of the endoscope, it is slightly inside the metal sheath. Why? Because if it is vertically, it drops or hits some structure, it should not have a damage. Tip lens, plus we are using a sapphire glass lens. The sapphire glass lens has a property that it is anti-scratch in nature, so you will not have any scratches. And I will tell in subsequent slide how to clean and maintain the endoscope to have a fantastic image, even if the scope is used for a very long time. And there are two types of light cables which are used. One, the most popular is a fiber optic light cable, and other is a fluid light cable. Of course, the light transmission is very good in fluid light cable, but the only risk is that if any of the sharp instrument makes a prick in the fluid light cable, then the fluid is lost, and then the life is gone of the light cable. So the preferred one is a fiber optic, which has hair-like fiber bundles. We'll see in a subsequent slide. Now what I will do is I will show you a short video how the endoscope is made, so that you will understand in the factory how this endoscope is made. Just a short video. I hope it's ready now. Video. Okay, the video is not very good quality. The sound is quite lean thin, but you just have a glimpse how an endoscope is made in the factory. Let's go a little faster. Come on to the main points. So I'll finish fasten the initial part of preparing the endoscope. I go a little faster on this.
Yeah, I'm not sure the audio is coming through there.
Yeah, so I just want to put some comment. The audio is really slow. So you see they are putting now the hair-like fiber bundle light transmission through the shaft, and then we'll be placing some rod lenses to the main points so that you understand how it is made. You can see the fiber bundles are coming out from the light transmission bundle, and then it is physically checked that there are no damage in the fiber bundles. Everything is manually checked. Also, we use special vectorscopes. Now these are rod lenses. They are also checked, and they will be placed in a series with metal spacers. So these are metal spacers there. So they give tensile strength, and it is decided that how much should be the air gap spaces with the rings. So the longer the rod lenses, better is the light transmission. So you can see that how the endoscope is further prepared. And finally, the ocular lens is engraved, and then physically every endoscope is checked with the angle of view that you have given. So this was in a nutshell to show that how an endoscope is prepared. So I further move on. Now I already discussed about the angle of view. So that the paramedical staff along with surgeons should memorize this, because they can accidentally give you a wrong angle of view when you're operating. So these are standardized: a 0-degree scope, green color, 30 degrees red, yellow, 70. 70 is used a little rarely. Of course, for frontal sinus tumor, it's pretty good. And also we have 120-degree white color. Black also has 12-degree and 45-degree. So that means the tip of the lens is actually cut in that angle. So what do we mean by these angled endoscope? If you see the horizontal axis in a 0-degree, it is completely circle. So even if you rotate your endoscope, you get the same endoscopic image. But when we are having a 30-degree angle of view, the last rod length is actually cut at an angle of 30 degree with respect to the zero horizontal axis. In 70 degree, it is cut at that angle so that you can see laterally. So that is why I was telling, when you are changing from 0 to 45 and 70, need not do a white balancing, and we can save a lot of anesthesia time, because white balancing color temperature is dependent on the color temperature of the light source, which is usually xenon light source nowadays. Now, how to handle endoscope, which is the main topic. Many times surgeons are using smaller diameter scopes, especially in neuroendoscopy, skull base. You are using 2 millimeter, 3 mm and 4 millimeter diameter. It is not good to hold the endoscope at the shaft by the paramedical staff and giving to the surgeon. It should be always held at the ocular lens, or one should always put a bakelite protection white color tube which we supply, or if it is not supplied, you can always order and buy it, and it is always safe to use that, and use the containers. Now, if you see the endoscope, when it is a therapeutic scope and there is a holder, many times unintentionally surgeon can lock it on the shaft. Now, what are the disadvantages of locking on the shaft? First of all, we are giving you about 14.5 centimeter the working length. That means if you are tightening on this shaft, you are losing this length, and sometimes you would like to go on the posterior part of the third ventricle and would like to see your structures like suprapenile gland, suprapenile recess, lamina terminalis, and by locking on the circular shaft, then it is not very comfortable. It can move a little bit here and there. So we have put a hexagonal area for locking your holder over here. There are 3 choices given to the surgeon. Some surgeons say ETV is a 15 minutes procedure. They do freehand ETV, which is okay. But sometimes you can have a long surgery like a colitis, like a suprasellar arachnoid cyst, or evacuation of intracerebral deep-seated hematoma, etc. And in those tumor resection surgery, it is good to have holder because your hands can get tired, you can take a rest, or you can use a Mitaka holder, which is like a robotic arm. Professor I.P. Cherian used in Nepal. So different options are given and one should use that. But when you use the endoscope, then you should make sure that you are locking over here. So otherwise, if you lock here, the other problem is you can damage the shaft. Or damage the shaft means there can be a dent. Once there is a dent in the neuroendoscopy outer sheath, when you try to push the endoscope, the therapeutic scope through the sheath, it will not go because there is a dent. And if you force, the first rod length can break, because it is said the strength of the chain is determined by its weakest link. So the impact would be there on the first rod length, which can break. Now, how do we clean an endoscope and always have a fantastic view as if you have just bought the endoscope today? It is possible to do that. What one has to do, I will show you at the end of the presentation. There is a special tube called endoscope telescope lens cleaner, and these are very small accessories. They hardly cost anything, and many times operation theater does not purchase, or perhaps the mistake of the sales reps, they do not tell the hospital, and it is just cleaned by normal water. There are 2 adapters here. You can open the first adapter and then the second adapter, and then take the paste, take some Johnson buds or any buds like this, use that paste here, then use the paste at the tip of the lens and the paste here. Now, by doing this, when you use this, you get a fantastically non-glossy image, absolutely clear image. And you say, I had been to one of the hospitals recently in AIMS Bhubaneswar about 2-3 months back, probably in September last year, and they told we were doing colitis. They showed me the video and the image was not good. And then I said, sir, it has not been clean. I took the paste, I just made a 5 minutes work on that, and they saw, wow, the image is fantastic now. So these are small tips and tricks. They help you. Why it is important to open these adapters? Normally paramedical staff don't open, they think it is expensive. By not opening, what happens is this place, it gets heated up. Because this is also a glossy image. When it gets heated up, there is blood debris there, it cannot be cleaned inside, and then there is a carbonization taking place. And when you are trying to push the light through the fiber optic cable, you are not having enough light going there, and the rod length gets heated up unnecessarily, and you find that I was doing surgery for 2 hours and I find a lot of heat there. So this is how you clean the endoscope. I will show you the paste at the end of the presentation. Now, yes, optics can get bad because these are mechanical instruments, and over a period of time, people are sometimes telling me that, oh, I like to put the endoscope in Sidex solution, glutaraldehyde, so that it doesn't get spoiled. Please note that these endoscopes have been tested in the factory for 1000 autoclaving cycle. So one should follow an aseptic technique. You can autoclave the endoscope on the recommended autoclaving cycle of 134 degrees centigrade, 5 to 8 minutes, 3 atmosphere pressure. There is no problem there, because if you dip in the glutaraldehyde Sidex solution, the issue is that it should be then put about 10 hours. People dip it for less time, and mind you, let me explain you what paramedical staff is doing. This is the Sidex tray, and it has a life expectancy. Suppose you put the date 1st July to 15 July is the life expectancy. In a hurry, her hands are going in the Sidex tray. She takes out the instrument, then she puts her hand there, either in another tray to wash it in saline, because you are not allowed to use the Sidex going inside the brain or spinal canal, or somebody is throwing the saline, another unsterile sister is throwing the sterile saline, but her gloves are now covered with the saline which has been thrown to clean the instrument. Again, these hands are going inside the Sidex tray. As a matter of doing this again and again cleaning, the dilution of the Sidex has taken place. So its concentration, which was supposed to be there for 15 days, is actually slashed down, which we didn't notice. So this is not a very safe method of doing it. So autoclaving is the best method, or you do ETO, ethylene oxide sterilization is another method. Or now there is another product which has come out. Carl stores do not make that, I heard, and some people use it, especially when you have one set in the hospital purchase and number of surgeries there, and you want a quick sterilization. It's called ParaSafe, para-acetic acid. It's a company from UK, and I had taken the literature of the from the dealer. We can always send it across through them. So once you dip, it forms a colorless, odorless solution, and it gives you a guaranteed sterilization in 10 minutes. The only issue is that once the solution is prepared, its life expectancy is 24 hours. So in the morning, if you have prepared a 4 liters of this solution with paracetic acid, you dip your instruments in, then next day at 8 a.m., within 24 hours, you must discard. So of course, they might have worked on the pricing accordingly. So this is there. Second thing is, sometimes the scope can have mechanical damage, and the optics can get bad. There are people who do not contact the proper Carl stores service stations or the reps, engineers. It is given outside, and they do not have these PAL vector scope. There are some special machines and tools which actually checks whether the scope is centrically loaded or eccentrically loaded or centrically loaded. And when you do an unauthorized repair, you still get a vision, but your axis is not coming in the center as I see in this picture. So try to get a proper service done at the proper company workstation, and do not compromise on these repairs, because you will not enjoy your surgery with true image. Now let's see the other issues which come. When the surgeon is using the flexible endoscope through the sheath, he has to keep this black knob which moves from 0 degree to 270 degree. But after he's finished the surgery, if he does not move it back to neutral position and he's trying to just take it out, so you can see the rubber coating gets rubbed against the tip of the sheath, and it can cause damage. Second thing is, if you are not using a video neuroendoscope, the chip-on technology which I had shown is the latest. If you are still at the old technology, and by continuous twisting and turning, there are chances that the fiber bundles will break, because if you are doing too much twisting, they will break and they will lead to these black spots. So what we suggest is take a gastric tube from the OT, cut a small piece, go through this and try to put it from this tapering area up to this place, because basically you'll be going up to this place unless you want to do an epiduroscopy going from the sacral hiatus, either doing a dorsal approach or a ventral approach, then you need the whole length. Otherwise you just need 35 centimeters good enough. So by protecting this, what happens is whenever you are moving it up and down, the impact is always in this area, because that's what we say, the strength of the chain is determined by its weakest link. And this area is protected by putting a gastric tube here and cut the tube up to this portion, and it's safe. So the recommendation from Stoll's factory is that if your area is covered by 25% black spots, then it is better to change it. And it is not possible then to, do a reanastomosis of these fiber bundles which break. These are very small here like bundles, and we will have to change the assembly here. So I think it's good to have the new technology chip on, because the visualization is not compromised. So this is another thing why it happens. And with continuous usage, yes, chances of bundles are going to break will be there, but one should be careful by putting this. So this is another thing. Second thing is the forceps which are coming with this. You can use a grasping forceps, you can use a biopsy forceps, and you can use a coagulator also, because if you have to do some therapeutic procedure, one must ensure that when you are pushing this, the lower lock is open, so that these are very small diameter 1 millimeter instrument. It do not get entangled here and break. And once they are going through this, make sure the instrument is closed and then it is pulled in. Otherwise, this can cause damage. Now, let's look at the light source. Now, most of the operation theaters across the globe has now very well accepted the xenon light source, and which gives you 6000 Kelvin temperature, a true white light. Now, in a layman's language, how do we get a good color? If this is my room, and if the room is dark and there is no light, then you cannot tell what is the color of my tie or what is the color of my shirt. So to see any object in the room, you need basically three things. You need luminance and you need chrominance. So by having a light intensity and having a color of the object, you can see. So this is important to have a light source which is close to the sun's color temperature, because if I want to see an object, I would rather like to go in the sunlight and then see the color of the object. Otherwise, in a little darker room, you cannot see it well. Now, when you use a light source, in a xenon light source, we give you a guarantee. If it is not a LED now, people have changed to LED which has 30,000 hours, but if you are still in the earlier version of the light source for cost reasons, whatever it may be, we give guarantee for 500 hours life expectancy. So moment 450 hours are over, can you see a bulb which is there? This bulb where I am pointing my arrow will start glowing red in color. It means 450 hours of your surgery is over. 50 hours are left. Please try to change the bulb. This is an indication. Many times in government hospitals, people keep working because a xenon light source does not get fused like a halogen. In a halogen, the tungsten wire breaks, it gets fused. Here, you'll still be working. And people say, no, why should I change the light, bulb? It is costing me so much of money. It's still giving me a light. Yes, it is giving you a light. Moment it crossed 500 hours, you can even go to 600-700 hours. What is happening is there is a load on the power supply of the xenon light source. And mind you, suppose the price of this, suppose as an example, is like $100 example, then $70 would be the price of the power supply. So people don't change the bulb, and when it comes to ask for repair, they say you are too expensive. The price of your repair is as good as buying a new one. So one should change. Now, how do we come to know that so much of hours have happened? You can open the top knob. There is a clock meter. We can find out how much is happening. And if you are changing the bulb, please give it to a proper engineer who changes it, because a xenon bulb has a very high evacuation in it. It's very high evacuation. If you just drop the xenon bulb like this, it will look as if a mini bomb has exploded, like in Diwali festival, but a major sound will come. So it is also important to ensure where the hand is touching, there is a high capacitor there. The job of the capacitor, it stores the electricity and then discharge. So if you are putting the hand and you don't have proper shoe and then you're barefoot, it can give you a shock. So these are some precautions we should take, and we should change the lamp. Also, many times I see on the light source, people put the camera head or the camera control unit or another unit. Please understand, the xenon light source, if you are using, also has its own heat and it wants to dissipate, and it also cools down. There is a fan, like you run a car which gets heated up, there's a fan, so there's a fan. So it should not be pushed, the trolley should not be pushed in the corner of the room, and it is not having enough ventilation. There must be a proper ventilation at the back of this, and maybe you can put in a fan. There should be air circulation at the back and not push in the corner, otherwise it heats up too much. So these are some precautions on care and maintenance. Now, endovision camera is very important. It's like you buy an iPhone or the top model of a phone, but you do not know how to operate all the features. People say, I'm buying 4K, I'm buying high definition, I'm buying this. It's good, but please learn how to use some of the very important clinical features which actually helps you in a surgery and not causing any trauma to some important tissues. I'm going to now explain with the form of video, which is very important for skull-based surgeon. If I ask some questions to the resident doctors when I am lecturing in some hospitals, that if you are doing a pituitary macroadenoma and you have identified the macroadenoma, you open the sella floor, you open the dura, and now you are curating out whatever method you use, suction technique or like Professor Kasam or Janki Ram use, or the curates. How are you sure that you have reached the anterior phase of the pituitary gland? You have reached the anterior phase of the pituitary gland and you have not accidentally traumatized the normal gland and not causing a post-operative DI function. This is very important, because while doing the surgery, there's some bleeding happening. It is looking red. How are we going to identify the normal gland vis-a-vis the pituitary macroadenoma? So here is a clue. Now I'm going to play a video and explain you how it is done. But before that, I'll tell you, if you get now the latest camera, the high definition camera of stores, which is called Image1S platform, it has some feature which you can always ask your rep, note it down, which is called Clara mode, Clara and Chroma mode. Now, when you come in front of the normal phase of the pituitary gland, or you feel you have curated out enough and gland is likely to come, you put this Clara Chroma button on, and you will see a light yellowish pancake appearance of the normal gland with fine vascularization going in the normal gland, which will not be seen in the tumor tissue. So this is how you identify by using this feature and avoid a post-operative DI function. And here we go on the video. I'll not play the whole video, but I'll just take you to the fine points. Here we go.
Is then brought close into the. On the right, the optocarotid recess is visible with the lateral sphenoid septum.
In skull-based surgery, it is said by Professor Janaki Ram that one must keep irrigating by warm solution at 40-degree temperature. It is said that warm saline causes vasodilatation and cold saline causes vasoconstriction. However, warm saline, when seen at 40-degree temperature, it enhances the eccentric pathway leading to coagulation and a very good hemostasis achieved. So when you are removing the macroadenoma, working in the four blues, you irrigate with warm saline continuously at 40-degree temperature. And I will just tell you what next step, how to find the gland.
Implanted on the paracellular carotid protuberance. The endoscope.
After you have removed it, you continuously irrigate, make sure all the small macroadenoma tissue clinging to the gland is falling down. Now you push the endoscope in like he has done. After pushing it, you come very close and now you stop there, hold the endoscope there, or use the parfocal zoom lens and put the Clara Chroma button on. Now look for that light yellowish pancake appearance of the normal gland and find vascularization. This is how you can identify and avoid a post-operative DI function of the gland.
Close into the cella for further inspection. Note the fall of the supracellular cistern into the cella.
So that's the advantage, the eye of the surgeon inside the canal to see over there. Of course, we have instrument for bleeding management solutions, etc. I will now be showing you some carotid injuries. I've removed the name of the doctors, etc. No voice, but it will be lessons learned how to use proper instrument and avoid such ICA injuries. So this was what I wanted to tell you. Whenever you buy any equipment, spend time with the sales rep or their technical expert of the company, whichever company, could be X, Y, Z, and spend time that what are the features which can help you to identify the tissue planes, the depth perception or color contrast, etc., because that helps you to deliver a good patient outcome. Most of the reps would be engaged in talking too much technical about lens diameter, etc., which is okay, that's their job. But finally, you are supposed to deliver a good patient outcome. As a patient, I come to you to reduce my suffering, my pain, and how this equipment can help. It's important to understand when you buy these type of equipment. Now, the next part is that the camera, which is bought, usually people say, should I use a single chip camera or I use a 2-chip camera or a 3-chip camera? Please note, there is nothing as 2-chip. Many times, a surgeon cannot grasp all the technicality. So it's either a single chip camera or a 3-chip camera, or now a high definition camera or a 4K technology. Now, in basic layman's language, what does an endoscope camera do? Now, there are basically 3 colors, which is called RGB, red, blue, and green. RGB, red, blue, and green color. So all the colors are actually derived by mixing these RGB color. These are basic colors. Now, in a single chip camera, it is one chip which has R, the red color, G, the green color, D, the blue color. So one chip looks after the luminance and the chrominance. So to see any object, you need 2 things. One is the light intensity. There should be a light in the room, and the object should have a color. So one single chip, which is called a charge couple device, it could be 1/3 of a CCD chip or 1/4 of an inch or half inch, it doesn't matter. But one chip looks after the basic RGB color, and then it is synchronized and you get a video image on the monitor. So in a 3-chip camera, you have 3 separate chips looking after each color's luminance and chrominance of red, luminance and chrominance of blue and green, and then it is synchronized. So obviously a 3-chip camera will give you a better image, a better resolution than a single chip camera. A single chip camera cannot give you more than 450 horizontal lines of solution, horizontal lines resolution. Many people say, I have single chip and you can go to 1,000 lines. It's all a sheer nonsense, because that's the highest capacity. A 3-chip camera can give you more than 750 horizontal lines resolution. So the more the horizontal line resolution, better is the image quality. And then we have high definition 1980, 1080, 2 million pixels, and the 4K, double of that. So this is in nutshell. I don't want to bore you with too many technical details, but this is in brief to understand what is single chip, 3-chip. Now, Many times the surgeon is switching off, switching on the light source during the surgery, because sometimes you are preparing, maybe you are preparing a facial lata or some type of a random flap, etc. So don't do that. There is a button on the light source. You can put it onto you know uh, standby mode. By continuous switching on and off, you are actually reducing the life expectancy of a xenon bulb if you are using a standard version of the xenon light source. Nowadays it is LED. The latest technology is LED 30,000 hours, and by the time you finish 30,000 hours, probably you have gone already 10-15 years ahead in your career, and something else will come. Now there is also what is called as a card edge connector. Now if you see the cable here, when you take out this cable, many times the paramedical staff are not conscious, it falls down. And here on the surface, you'll find there are 10 electrodes on the top and below. That means there are almost 20 electric wires which are running through this. And by dropping it, it can get damaged on the edge. You still get an image, but you're not very happy. So if you break these wires by continuously twisting and turning, then it is not possible for us to re-anastomose these 20 electric wires going in the camera cable assembly. We will have to change it, and there is a cost factor involved which you will not be happy to pay. The hospital will not be happy. So these are the precautions that we have to take. And also I told you that if you have a light cable, try to roll it in a bigger fold. Do not twist and turn your light cable. If you do twisting and turning, inside the light cable, there are 16 to 24,000 hair-like fiber bundles. So by continuously twisting and turning, you are actually breaking these fiber bundles. So if you are broken, you can still get a light when you connect with the endoscope, but it is heating up. And surgeon says, I'm holding for 2-3 hours, I feel too much heat in my glove. So this is why it happens. So I will talk about high frequency. Many times there are small, pricks on the shaft of the electrode, but still it is functioning. It can happen through wear and tear, or while changing it to the shaft and the handle, because these are take apart. It can happen. But when it happens, you please send it for repair. We change the whole insulation. Do not run it with the little pricks here, because this will cause a high frequency leakage of the current in the bipolar electrode, and this will burn the tissues, and it will not going to help. It will have a short circuit. So this insulation needs to be changed, and one should not carry by putting a 3M tape. Many times in smaller theater setup, they just put a 3M, it's still working. Yes, it can work, but this is not a healthy situation. It can burn the high frequency. Now I will talk about induced chloride pitting. Many developing countries have very hard water, and after every surgery we are continuously using this hard water. It is not possible to have a water of drinking quality, a less hardened water, and clean the instrument. Probably it will be very expensive. So we are using this. So long you have the silver polish and the silver content which is there on the shaft of the instrument, which is like a paint, there is no corrosion happening. But as it continues working and the hard water, it starts corroding a little bit, and then what is called as induced chloride pitting. These instruments are put together with one another instrument in a trolley. It is transported, etc. And after the surgery, it is not sometimes dried, so there is some moisture, and this gets like a communicable disease transferring from one instrument to another instrument, and that's how the corrosion happens. So how to avoid this? I will going to be talking about two types of cleaning. One is short-term cleaning, periodical cleaning, and a long-term cleaning. So in subsequent slides, I will talk about that. Now here is the situation. Probably the surgery happened around the lunchtime. It was a long tiring surgery. There's example of laparoscopy trolley, doesn't matter, but at the end of the day, the equipment are usually the same. People went for lunch, and after 2 hours, 1 hour, you come, there is no surgery further. And then what happened, the blood debris has got into nooks and corners of the different area. Now this is a forceps. You see here, it has a tip, the jaws, and what one should do is there is a periodic cleaning. You can use a tray, a like a Sidex tray with a water at least of drinking quality, and then you put decalcifying agent. Some companies are making like Johnson, etc. You open all the instrument to whatever capacity you can open by removing the inner tube of the working forceps of the hand instrument, the outer shaft, the handle, and you dismantle whatever you can do. You put in this lukewarm water at about 40-45 degree temperature for a period of 30 minutes to 45 minutes. So all the blood and the debris which has got in the nooks and corner is going to disintegrate, and finally you remove from there. Then you go in the washroom and you then clean it. We also supply a special brushes which can go through these small shafts opening and through your neuroendoscopic sheath, and they can clean. On a routine, they usually have a toothbrush type of thing, and it is always clean from the surface, which is not enough, which you can see one toothbrush is lying there. So there are special brushes I will show you at the end of the presentation. And by getting these accessories, which are not expensive, the life expectancy of the equipment goes. Because if we do not clean the tip of these forceps jaws, there are laser welded rivet joints. And once the corrosion happens and you hold a tissue, maybe it's a little tough tissue for the tensile strength of the instrument, and you grab it, the rivet joint breaks. And then these repairs are expensive. So this is a precaution. Of course, there are ultrasonic cleaners now available. One can use that. Please mind you, these ultrasonic cleaners are vibrating at a frequency. The water which is put there or the disinfectant solution vibrates at a frequency of almost 50,000 times a second to disintegrate the blood debris which is there. Mind you, please never ever use the endoscopes inside this and the camera heads. Why? You saw in the video, in the endoscopes, there are rod lenses which are at a certain distance, and there is metal spacer for the air gap spaces to be maintained. So if the endoscope vibrates like this, these air gap spaces can reduce and you will not get a good clarity. So the rigid rod lenses, the fiber scopes, and the camera heads are not supposed to be cleaned in the ultrasonic cleaner. However, all other hand instruments can be cleaned with these, there is no problem. Now, this is what I was trying to explain. If you see in these forceps, of course, in neuroendoscopy, the forceps are still smaller, and this is where you have the laser welded rivet joints. So in engineering language, we call it rivet joints, and they hold both the jaws to work. And this area is not properly cleaned. And due to corrosion and induced chloride pitting coming from another instrument, the rivet joint breaks, and then the repairs are expensive at the end of the day. So we can avoid this by doing this periodic cleaning. Now, I am going to talk something which we see that sometimes the place is not enough. People are putting one, the pump system, above that is a light source, above that is a camera system, above is the drill console. So one instrument above another instrument. We should not do this. These are working on PCB, and then you have electromagnetic induction happening. It is dissipating its heat, plus it has its own current which is flowing. So while you use a cautery, many times, especially in urologies, if you use a cautery, they say, when I use cautery, I see lines coming on the video monitor. Now, this line is happening because of this electromagnetic induction induced by having one unit above another, and they find lines. When you put a gap, you separate it out, or your cautery is very close, or you have put in one phase. Normally, you have a three-phase connection to take a bigger load. Some operation theaters, small hospital, B-tier, 3-tier cities, they have single phase in which you are connecting all your units like your camera, your monitor, your light source, and also the cautery. So the cautery should be connected in another phase, not in the same phase. If you connect in the same phase, this will happen that when you use cutting current or the coagulating, you have lines coming on the video monitor, which is disturbing. And it is important to use the correct rating of the fuses. In our country, in India, some developing countries, I think everybody is an engineer working in the operation theater among paramedical staff. Anytime a fuse goes, they say, I have a fuse, they take it out from somewhere and put it. Please note that if the unit is telling is a 15 ampere fuse, a 15 ampere fuse has to be used, not a 5 ampere fuse. So it's a little technical, but you should be knowing that if proper people are doing the proper repair job, who are qualified to understand what should be the rating of the fuse. Another thing is that sometimes inside the part of the drills, neuroendoscopic drills you use for endonasal work also catches inside fitting. It is important to have the kava spray there so that it is always lubricated, doesn't heat up, and you does not have this type of situation. And then you should use a silicone oil also, which is there, the kava spray silicone oil, medical grade. Now, why it is important to have a medical grade oil? Now, the oils have different viscosity. When I was studying engineering, we were taught, oh, this is viscosity 40, this is 60, this is 80. So for the special medical instrument, a special type of viscosity is defined. It is not that I use the oil in the hair, so okay, it's also a lubricant, so let's use it. So proper viscosity should be there because that defines the heat dissipation in the capacity of the equipment. Now, this is a kava spray. I think many of the doctors know, but you have to ensure the paramedical staff keep using on the drill, the high-speed drills. Otherwise, the handle PC motor gets bad in an early stage. Now, at times during storage, we find these are long instruments, especially being used through a video neuroendoscope, flexible fiber scopes. And while packing it, the box, it should be rolled or curled. They are put straight, and sometimes during packing, it can catch damage like this. So these are the areas which are vulnerable to damage. And then using this type of forceps coming out from the sheath and bending down can also cause injury to some vital structures. So this needs to be looked into. Now, it's often said that sterilization is no substitution for cleaning. Instruments have to be thoroughly cleaned. They have to be thoroughly inspected, and we run a program called EndoProtect. That means we have softwares, we have a dedicated team. You can ask them to come. Now we have a team in Singapore, also in India. They will come with all eyepieces, everything. They will do tray auditing in the operation theater. And these people have been trained. They can find that, sir, this instrument is not going to last you in next 3 or 4 cases, although it is looking quite well. We have optical tools to check the quality of the vision of your endoscope. Please come forward, do the auditing trays. Expert from the company, wherever you buy, whatever endoscope you buy, you should call them to do auditing tray. And this is a preventive maintenance, and they can tell you, sir, this instrument is likely to change. If you have one single instrument and it's going to break there and you don't have a standby, you are really stuck. So lubrication is important, and it should be stored in a dry area. I see the sisters take a cloth, they clean the instrument, the same wet cloth. They should have a hair dryer, which they use after the bath. The instrument should be totally dried, dismantled, lubricated, and sent. Once it is on the sterile trolley, it cannot be lubricated. It does not follow an aseptic technique. Now, this is the cycle on which one should use. That means the instrument is dismantled, then we go for manual mechanical cleaning or ultrasonic cleaning, or you use the brushes, or the way I told you, you put in a disinfectant solution, decalcifying agent is put, and in a water of drinking quality, you rinse to dry, you visually check, you do tray auditing, you lubricate, then you assemble, and then you send it for sterilization. So these are the protocol which should be followed, and instrument has to be clean, and that does not, sterilization is no substitute for cleaning. Now, to have a healthy life of the equipment, this is the parameter which should be followed, but it is easier said than done. Theoretically, yes, the hardness of the water is defined, the chloride, the salicylic acid, iron, magnesium, copper, but at the end of the day, whatever water comes in your operation theater has to be used. And we say water of drinking quality. That's why after every 2 weeks, fortnight, you should get water of drinking quality, 3 to 4 liters prepared, little warm, 40-50 temperature, put decalcifying agent, and then dismantle instrument. And every 2 weeks, depending on the workload, sometimes you may not operate for 1 month. So this enhances the life expectancy. So to conclude, this is a snapshot which you can see all these items. These are small accessories. If you have this items, I have written also the catalog numbers. You can take a snapshot, ask the rep. They will enhance the life expectancy of the equipment by 4 times minimum. Now you look at this gun. This is a pneumatic gun which can be fitted into the wash basin where the sisters are cleaning, and there are different nozzles. So they are air jet nozzles, and when you water comes here, it flushes with the like a jet. If you see the way they clean the cars with the heavy mud embedded, so the same is like this gun. And then you can also push in the decalcifying agent through this, and when the water comes out of the jet, it also comes with the decalcifying agent. Now this is the special the lubricant or the cleaner for the telescope. You saw that I was showing that the surgeon is using the buds, and or the paramedical staff is using the Johnson & Johnson buds to clean the tip of the endoscope, the place where you put the light cable and the ocular lens. So this is the telescope lens cleaner. Now this is a special lubricant for the stopcocks. That means the neuroendoscopy therapeutic sheath has an inlet channel and an outlet channel. So when you open the lower lock, there are nuts there and they have threads. During corrosion over a period of time, these threads are going to worn off. So even if you close, you will find the artificial CSF, the RL is coming out, and you're not happy. So when you lubricant, it's like a lubricant of the cycle chain. The threads are intact and it will have a long life expectancy. Now this is a transparent silicone oil dropper. You can take this bottle, you can open and put silicone oil through this. There is a button here, and when you press this spring, the final tip goes in and out. So it will bring precise drop of the oil, and all mechanical instrument where you have jaws opening, where there is a rotation, must be oil with the medical grade silicone oil which has the right viscosity, and that enhances the life expectancy. As I said earlier, that so long the silver content and the silver polish is maintained on the hand instrument, it is difficult for corrosion to occur. Here is a bottle where you can see it has a special number also, 27658. This is a silver polish or called Duraglit. When you open this, there are cotton swabs with the silver content. Like you see in your house, you have different brass items and you polish it. So same, you take this once in a month or fortnight, depending on workload, you ask the sister to sit and to polish these instruments. That means so long the silver content is maintained, the induced chloride pitting will not happen. So this is a snapshot of what it is there. This is the state of the art, the service center in India, and it's good to send equipment to the right service center. We also have what you call care at the doorstep. This is a van in India. Of course, we are not traveling the whole of the country. It's not possible, but around 300, 600 kilometers. This is like a rescue van. You have like ambulance. So all equipment is put here. The workstation, the engineer can also sit. It is fully equipped, loaded. We travel to small hospital, B tier, C tier cities, and then we do pre-auditing and we check that they can repair it. Now, this is important to understand in developing country. It's little physics technical, but what it means and why the equipment gets spoiled. If you see today, the electronics or microprocessor based circuit technology, and sometimes the voltage which is coming, you have to see whether you are using NTSC or a power system. And if you are using a power system, the recommended voltage is 220 to 230 volts at 50 hertz of frequency. And sometimes there is a sudden rise of voltage coming from the main AC volt, which could be for just micro millisecond. I'm not even calling 1 second, micro millisecond. Now this sudden rise of voltage going up to 400 to 800 voltage is sufficient to damage your PCB microprocessor based electronics components in the camera control unit, or your other components in the light source, etc. So what should we do to have precautions? So we should have a spike protector or a surge protector. There are good companies like Allen Nova, Burji, Blue Bird, Blue Star. It's like you buy a stabilizer for your air condition 4 kVA. So similarly, what we are doing is, what is the job of a spike protector? A spike protector looks like an extension board. It has two capacitors here. The job of the capacitor is to store the charge and then discharge the charge. So these two capacitors, C1 and C2, whenever there is a spike, a high voltage coming in, it immediately stores the high voltage and takes it in and then send it through the earth down. It will not allow to go into the electronic equipment, and that's how the life expectancy goes up. So it is important to connect all your camera, light source, all electronics through a spike protector, or you can use a voltage stabilizer, or online or offline UPS, that's uninterrupted power supply. Online is called UPS, uninterrupted power supply. So then your equipment is safe, especially the electronics part. Now, how do we make a connection? So this is a simple line diagram to understand. This is my AC mains, which is coming. You from the AC main, you put any of these, which is called, best would be a UPS, uninterrupted power supply, which you use for desktops or online or offline, or a CVT, constant voltage transformer. And from here, you connect a spike protector, which looks like an extension board. And from spike protector, you start connecting your different components, endoflator, camera, light source, monitor, etc. So this will safeguard your equipment. Do not run the equipment directly coming from the AC voltage directly to the equipment. So this will not take care of the spikes and surges, and especially in small developing countries, B tier, C tier cities, these issues are happening. Now, how do we find that what should be the rating of the voltage stabilizer or uninterrupted power supply we should purchase? We read in physics when we were in school, you were also in school, you read it long time back. The power is voltage into current and a cos factor theta, which is taken 30 degrees. So to get a power rating, we multiply the voltage with the current, which is 1.5 amperes in current, and the cos factor 30 degree. So when you multiply this, this is how you get the rating of the power, that what is the power rating. In this case, it comes to 276 watts. So for a surgeon not to get too much technical into calculations, we have actually standardized, and you can see that in Endovision camera approximately takes 40 VA voltage ampere, and when you do that multiplication, the wattage power comes. So finally, when you add up a video trolley, your total power consumption would come around 1530 voltage ampere or 1223 watts. So you take a higher grading, and if you are planning to add more equipment, you take the next level of the UPS or constant voltage transformer, which could be 1.5 kilowatt ampere or 1500 voltage ampere or 2000 or even higher. So that's how you calculate the rating. So you can always ask the technical guy about this, provided he knows, and this is how safe. Now what has happened is, if you look at the operation theater, when they were designed, it was not kept in the mind, especially in government institutions, other places, how much equipment is going to come. We kept adding equipment as the budget came, as you started progressing, we kept adding. Now look at the way the equipment is being added with the limited operation theater dimensions. Now, this gives to congestion of the equipment, so many wires and hanging, and the OT looks like absolutely standstill. Now, this type of thing, when the surgeon is giving a command to the sister here, hey, please see, that I'm not getting enough light, what's happening? No, she is still holding an instrument, trying to see. There are so many wires, cannot understand the cautery wire, the light cable, the IV wire. It's absolutely quite confusing. So this type of technology is a redundant old technology. What can be done? Cannot understand which cable is not working. And this is not acceptable nowadays to any doctor during the surgery and trying to find out. So this is the operating room of the future. We have a special department. During my next talk, we will discuss more in detail. No wires hanging, all ceilings suspended and centrally controlled. This is the OR which a surgeon would like to work. We will have a talk during my next session or detail on this. Now, let's get into a little more how to avoid complication, the use of equipment. You saw that on the third video of ETV, the surgeon was using a scissor to open thick arachnoid strand and he was having difficulties. Although he did it, Henry Schroeder is quite experienced. After that, we developed this instrument called guillotine knife. If you look at the instrument, those who have done skull base, it looks like a dural knife, like Capablanca knife. This is absolutely atraumatic. There is no sharp edge. So when you press this knob, the knife comes and travels between this end to this end and cut any tissue which comes. So you actually hook it like this, the thick arachnoid strands, and you use the knife to cut. And I will like to demonstrate this with the form of video. And after that, I will also talk on bleeding management in ventriculoscopy, one of the major arterial bleeding while doing a interhemispheric arachnoid cyst. How to manage bleeding and complication, will also talk on this. So right now I'm trying to show you that what is the advantage of guillotine knife.
This video shows a comparison of cutting an arachnoid membrane overlying an artery with scissors and with a guillotine knife. Using scissors, the tips of the blades point towards the artery, with a risk of cutting into the artery. Using the guillotine knife, the membrane is elevated from the artery with the foot plate.
Now you see, he's using a scissor. Instead of scissor, now you see guillotine knife.
Damaging structures located under the membrane. By using the guillotine knife, the risk of cutting into underlying structures can be avoided. The footplate of the guillotine knife is placed under the membrane, which is then slightly elevated.
So he has hooked the arachnoid strand here, the liquid membrane. This is very safe. Below our structures, very safe. The knife is only traveling here and it is going to cut the liquid membrane.
No neurovascular structures are incidentally trapped. Then the blade of the knife is pushed downward into the footplate. Thereby.
So he's hitting here. So this is safe. This is like a guard and you can cut these thick arachnoid strands. So that video which showed dealing with this to establish the communication in the subarachnoid space can be established.
In summary, the guillotine knife allows very safe sharp dissection in intraventricular endoscopy.
Now I'm going to take you through a complication. One should not have, but let's also see, suppose it has. What can we do? How can we avoid? Of course, if there is a direct injury to the basilar artery, then nothing can be done. And I haven't seen somebody doing that. But this video I'll show you and I'll explain you what the doctor has done to, come out of this issue. This is a case of while doing an interhemispheric arachnoid cyst, one of the vessel was hit. And when it is hit, he managed it, and what he calls is a chamber technique in the video. Because once I play the video, you will have a readout. You will not be able to see. So I'm trying to explain you that what is being done. You will open the lower lock, which you saw in the video, and you withdraw the endoscope by 1 centimeter, where you were seeing the edges of the sheath, if you remember that video. So when arterial bleeding happens, you just open the lower lock, withdraw the endoscope inside the sheath by 1 centimeter, and that becomes your artificial space. So if you are now irrigating with a normal IV stand with IV tube under gravity, that will not help. You take a transparent tube which we also supply, and with the manually with the syringe, 20 cc syringe, you take RL and you start flushing it, and continuously you are irrigating, and you use a micro suction from the lower lock of the sheath and you start sucking out. Please ensure your irrigation speed is slightly more than suction, otherwise the structure comes out. And when you start seeing the vessel, the place where it's bleeding, immediately take the endoscope very close to it so that you have a continuously irrigation like a jet there, and then you will use a special bipolar which I will show you. So let's see the video to understand what was done, and there is always good learning from others.
This video shows the hemostasis technique when a major hemorrhage occurs. This is the only case of arterial hemorrhage encountered by the author in his ventriculoscopic series. It occurred while fenestrating an interhemispheric arachnoid cyst. When severe hemorrhage is encountered which obscures the view completely, the endoscope must not be moved. It should stay in place and forced irrigation should be initiated. After obtaining some vision, the endoscope is slowly moved towards the bleeding vessel. The endoscope is then withdrawn into the sheath, and the tip of the sheath should be positioned as close as possible to the bleeding vessel. The space in front of the lens within the sheath can be irrigated easily to assure clear vision. Thereafter, the bipolar diathermy probe is positioned exactly at the bleeding vessel. With gentle pressure, the vessel is compressed to stop the hemorrhage temporarily. Next, with continuous irrigation, the field is cleared and the anatomy identified. Then the bleeding vessel can be coagulated to achieve final hemostasis.
So now watch out. The moment I play the video, they'll be read out, and then there's no need to panic, nothing, and just stay there and move the scope inside the sheath and watch out.
During fenestration of a midline arachnoid cyst, an arterial hemorrhage occurred. A readout occurred immediately, completely obscuring vision. In such situations, the endoscope must not be moved. Vigorous irrigation with lactated Ringer's solution is initiated. Only when the first structures can barely be recognized is the endoscope slowly advanced toward the source of bleeding. The endoscope is withdrawn into the sheath to create a small space in front of the lens. With forced irrigation, this space can be easily cleared so that good vision is obtained.
Okay, this you see is a special bipolar. It is not a monopolar, it's a single sharp, and this white thing which is there has got a ceramic insulation. It does a precise coagulation at the tip, does not leave any lateral thermal damage, or let's put it, the minimal lateral thermal damage to the adjacent tissue, does not leave necrotic tissue, and that's a fantastic bipolar what he's using. So after he could see, he immediately pushed the endoscope in, coming very close to the vessel and just concentrating there.
The bipolar electrode is advanced to the source of bleeding, and the vessels are simply compressed to achieve temporary hemostasis, which enables anatomical orientation. With this small chamber irrigation technique, good identification of the bleeding vessel is possible and safe coagulation is performed. The utmost care is taken to ensure that the main vessel is preserved and only the bleeding.
You have to come close, use the zoom. Your sheath and the endoscope should be very close to the bleeding area.
Right branch is coagulated.
And stay there. So this is a learning, and of course it has been managed quite well, and that's why the video is here, so that we learn from others' mistake. And moving on further, now this bleeding management issue I just covered. Now I will also say that it is very important to have proper equipment. Sometimes, the budget is less, and there is always a feeling that, oh, I already have a Fogarty catheter from vascular surgery department, etc. We can manage. Yeah, many things can be managed. And I said, sir, neuroendoscopy and skull-based surgery is training the pilots, and pilots do not come back and tell what went wrong during the accident. Keeping that in mind, this is another video. I've removed the name of the surgeons, etc. They are all my friends, and they give me these videos so that I can help other young doctors to learn from their mistakes, or probably those days the trainings were not so many. So let's see, and I will, this has no voice, so I'll be commenting in this, and I'll not play the whole video, a little bit, that what can even cause with Fogarty catheter. Here we go. I directly go to the main point. Now here is a Fogarty catheter, which is a vascular one, probably of 4 or 5 frames. The surgeon did not use the deck forceps or third ventriculostomy forceps, directly opened it like this. And after that, you can see there's still a liquid membrane is intact. And then you can see the glimpse of the basilar artery there. Then obviously the Fogarty catheter has to come. This is not a proper Fogarty catheter. You see, it's too big here, and the place where balloon is not now going to be inflating, this is a very long distance. Of course, it was available in the OT. He didn't buy it because to save cost, which is justified. But this is not a proper one. And you can see the basilar artery is there. Now he's hitting against the basilar artery and trying to enlarge it. And you see a small tiny bleeder happens, and just the bleeding gets more and more. And luckily I was there seeing, and I told him, sir, please use this special bipolar and it will help you. And this situation was handled. Now you see. You can see the glimpse of basilar artery being compressed every time, and you see how this vascular Fogarty catheter being used. And this is definitely not very well appreciable, but this is a good video to learn. And sometimes surgeons are also very busy, cannot go to all training programs. You can see a air bubble also coming in, and now a small sputter, a bleeder has happened. Okay, it starts bleeding more and more. You can see a small a hematoma was also seen at the end. So I just go to the main point and show you that special bipolar probably was mistaken by the sister as a monopolar, because it is a single shaft instrument, and that did a great job. You can see the bleeding is now increasing. Further it is increasing. And this was an incomplete surgery because the surgeon couldn't manage to open the iliacus membrane, and the CSF at the subarachnoid space was not established. So you can see further increasing. I go a little more faster, air bubbles now coming and disturbing the view. Okay, I can show you the shots. 2 shots were done of these bipolar. You see the liquid membrane very stiff. This is the bipolar, which was not known by the paramedical staff. It's important for the paramedical staff to be fully trained on the equipment. In fact, you should conduct their exam and check they know everything. This is the same bipolar. Luckily, I was there. He called me to support, and I told her, ask the sister to connect this. And it was connected, and it did a great job there. 2 shots. It was taken care. Of course, he then further continued, and you can see a little hematoma also happened. The bipolar did a great job there. So you can see it still entered. There was a hematoma formed here, but this was improper instrumentation. So it's important to be very skilled. Yes, skills are necessary, but proper instrumentation. The hematoma is formed over here. Of course, still not a complete surgery because could not open the iliacus membrane there. You can see it's all closed here inside. So this is a learning from this video over this. Now, let's see why it was stressed. I told you this balloon inflates not circular first, it's more of a cylinder. So your floor of the third ventricle will not slip, and this distance from the tip and the place where it inflates is very small. It's a 3 French Fogarty catheter, so you will not land up opening more than 6 to 7 mm, which is defined in the books, which is good opening. Instead of using a forceps like this, which can slip in more deep, could be more risky, you better to use a forceps like this, which is a third ventriculostomy forceps. Numbers are given for easy identification, and then you already saw how it is used. So we'll also talk a little bit on equipment for skull base, bleeding management issues, and I will go through some of the carotid injuries and how to avoid that. If you see, one should have a cluster of instruments for bleeding management in skull base. Many times surgeons say, oh, it's okay, I'll just have one bipolar and that's enough. At times, there is a small prick on the carotid. When a small prick and you have tissues which are nearby, you can take this type of forceps, which is a 4 millimeter, and along with the tissue, you can coagulate. Very small minor prick. From Mechaner's artery, the persistent trigeminal artery, you can take this and coagulate, and it forms that collagen and helps in hemostasis. So one must have a cluster of complete bleeding management solution with different angles. Now you can press the button, you can move the shaft 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock, and not just compromise with one instrument doing everything. We'll also see that if a surgeon is a microscopic surgeon and he says, now I do maximum thing with this and endoscope is not really needed, required, can we marry an endoscope with microscope? And this type of endoscope is called the Gauzy endoscope. It is a special endoscope, 2.7 mm with an angled eyepiece. So here the eyepiece is now angled at 45 degrees so that when the surgeon brings a microscope, it will not come on the way. And this is a very good endoscope for doing an endoscopic deep-seated intracerebral hematoma. I have videos on that. Maybe my next lecture we can use that. So these are the endoscope. So let's have a look at one of the surgery, how the endoscope was used in a case of a trigeminal neuralgia and a hemifacial spasm, and in the case of a trigeminal area where the branch of the superior cerebral artery was pressing against the trigeminal nerve near the Meckel's cave, and the surgeon dissected between that, put a Teflon and used their angle scope to find that there was nothing adherent there and everything was there. Here we go on the video.
This 87-year-old male patient had been suffering from severe trigeminal neuralgia in the mandibular nerve, V3. Even when treated with drugs, he was hardly able to ingest food because of the unbearable pain. The CIS sequence of the MR imaging revealed an obvious compression of the right trigeminal nerve by a loop of the superior cerebellar artery. The patient is positioned supine with the head tilted to the left. The trigeminal nerve is approached by a superior retrosigmoid craniotomy. This is done by performing a retroauricular curved incision and deflecting the musculature from the bone subperiostally. For the osteoplastic craniotomy, which borders the transverse and sigmoid sinuses, 2 burr holes are first placed near the sinuses in order to detach the dura from the bone flap safely and so prevent hemorrhaging from the sigmoid sinus, particularly in older patients. The bone flap is then cut out using the craniotome. The bone flap is carefully detached from the dura and removed. The craniotomy is approximately 2 by 2 centimeters. After the dura has been opened by a curved incision parallel to the course of the sigmoid sinus, the microsurgical exploration is performed. Once the cistern has been opened, the cerebellum falls back, enabling surgery without retraction. After incising the arachnoid, the trigeminal nerve becomes visible. The inspection with the 0-degree endoscope provides a good view of the anatomy in the dents. The trigeminal nerve is visible, severely compressed by a loop of the superior cerebellar artery. The perforating branches of the SCA are also well visualized. The inspection with the 30-degree endoscope allows even better visualization of the compression. Additionally, we see how the cerebellar artery splits into two branches. The loop of the cerebellar artery is then detached from the trigeminal nerve and luxated out under microscopic control, resolving the compression. To do this, the arachnoid adhesions are dissected, partially sharply and partially bluntly, to achieve a complete decompression of the nerve. The arachnoid is opened far laterally along the course of the superior cerebellar artery to provide sufficient space for mobilization of the loop. Once sufficient space has been created for the loop, the superior cerebellar artery is moved laterally so that the trigeminal nerve is totally decompressed. A Teflon pledget is inserted under microscopic control. The Teflon is inserted between the superior cerebellar artery and the brain stem to keep the artery away from the nerve's root entry zone. A second Teflon pledget is inserted to prevent the superior cerebellar artery from compressing the trigeminal nerve distally. The final inspection shows the good decompression of the trigeminal nerve and the preserved petrosal veins. Following successful decompression, the dura is closed watertight with a running suture. After fixing the bone flap with 2 craniofix, the wound is closed in layers.
So let's see, in the case of a hemifacial spasm, use a retrosigmoid approach as we saw in here.
This 66-year-old male patient has complained of a permanent right hemifacial spasm for 12 years. The botulinum toxin injections were only initially effective. Prior to the operation, the patient was suffering from a severe hemifacial spasm with tonic and clonic components. The CIS sequence of the MR imaging revealed a compression of the right facial nerve at its origin from the brainstem, caused by a loop of the anterior inferior cerebellar artery. The approach is created via an inferior retrosigmoid craniotomy. First, the arachnoid covering the lower cranial nerves is incised and the prepontine cistern opened. The lower cranial nerves are exposed up to their origin from the brainstem. Microscopically, the compression of the facial nerve cannot be seen directly without retracting the cerebellum. The endoscopic inspection clearly reveals the compression of the right facial nerve at its origin from the brainstem, caused by a loop of the anterior inferior cerebellar artery. Under microscopic control, a Teflon pledget is inserted between the cerebellar artery and the brainstem in order to remove the vascular compression completely. The final endoscopic inspection shows the successful decompression of the facial nerve.
So you had a glance that how this can be used. This is a special Gaussian endoscope. These are long Safarian instruments and also shaft instruments, the special endoscope. And this gave us some. Now let's see what should be the proper collection. We're going to talk on skull-based surgery. Some says I want to do skull-based, but you want to do skull-based with extended approaches or just basic. There are some instruments which are used in the nasal cavity, which look like the functional endoscopy sinus surgery. So this short video will give us an overall glimpse of the equipment which is used in the form of the video. Here we go.
Erkennt man nun die normale conventional microscope? Endoscopic transnasal transsphenoidal pituitary surgery is a modification of the conventional microsurgical technique. The advantages lie in better illumination of the surgical field and controlled tumor resection. In principle, all hormonally active and hormonally inactive microadenomas and macroadenomas can be operated on using the endoscopic transnasal transsphenoidal approach. For pituitary adenomas growing a long way para, supra, or retrocellularly, extended skull base approaches under purely endoscopic control are necessary. A completely new set for pituitary surgery has been developed. It comprises the following instruments. Endoscopes with a 0, 30, and 45 degree direction of view, color-coded for ease of identification. Special suction and irrigation sheaths are required for the endoscopes. Their distal ends are beveled as appropriate for the telescope used, and they are also color-coded.
So the red color scope, if you're using 30 degree, then red color sheath. If you use with a 0, the sheath is circular, so you will get a half cut on the monitor. That's a precaution.
To ensure intraluminary sterilization, the use of a cleaning tube and attachment is recommended.
It's for cleaning purpose. You can flush in the water here to clean it.
The use of a sterile change adapter
This adapter we already discussed in the first part of the video.
allows fast switching between telescopes during the operation. The Tumfahrt handle is used for intraoperative cleaning of the endoscope. It features a push-button valve.
Now this is a handheld cleaning device. Now many surgeons hold it by hand, just the scope, and then every time it gets fog, so you have to come out, you have to clean it with the Savlon or the water and again go back. So this sheath we put on the top of the scope, we put the Tumfahrt handle. One side is irrigation, one side is suction connection, and automatically when you press the button, it keeps rinse and clean it, and you can continue with the surgery.
For regulating the flow of irrigation liquid.
So you will connect your irrigation from the IV stand, the IV tube, one tube here, and suction. That means you need 2 suction machines, one for this device and another for your real surgery.
And a separate suction and irrigation channel. The handle enables the surgeon to work more ergonomically.
And if you are doing extended approaches, then we give you a long endoscope with the same handle. If you want to go right from the planum sundale to down up to the base of the C2 vertebra for transodontine approaches.
The flow of irrigation liquid is guided directly onto the telescope via an elevation on the inside of the sheath, thus cleaning the telescope. By increasing the flow, the surgical field can also be irrigated. The nasal speculum is only used at the beginning of the operation to place sponges soaked in sympathomimetic drugs. Nasal dressing forceps can be used to place sponges in the nasal cavities or materials for closing the dura mater. Various nozzles are used in addition to the endoscope suction channel.
Now teardrop suction tubes are preferred. If you are doing the Pittsburgh group principle, what Janaki Ram does, the Kasam and all that, Paul Gardner, they use two suction technique rather than curating out the tumor. So then there is a suction tube has a teardrop like this. You can regulate your thumb on the top and regulate the suction speed what you want depending on the kind of tumor you're dealing.
For stemming nasal mucosal bleeding, conventional bipolar coagulation.
So this is also a monopolar bipolar with inbuilt suction channel. So sometimes surgeon is doing a single nostril technique, a small pituitary microadenoma, which is okay. And then you can, from one nostril, you can use this tube, you can coagulate and also do suction.
Coagulation forceps are sufficient. Focal bleeding can be stemmed with a monopolar suction coagulation cannula.
And this also helps you in doing an endoscopic assisted deep intracerebral hematoma evacuation. Same instrument can be used.
Thanks to the tubular shaft design, the take-apart bipolar forceps can reach and coagulate.
Now, the important technical part of this bleeding management issue, a bipolar, maybe you coagulating the branch of the sphenopalatine artery or the Mackenzie's artery, persistent trigeminal artery, doesn't matter, that when you hold the vessel here to coagulate, you see this shaft, every time he press the handle, this shaft is actually moving. So the vessel which is held here is not moved like this. It is not retracted. It is being held there. The shaft moves and the closure of the instrument comes so that the current can be passed and you have hemostatic effect.
Vessels situated deep in the tissues.
So it is just closing here. The shaft is moving. So that's the modification.
The different shapes of the distal tips of the...
So you can, by pressing the button outside, you can move it at 12 o'clock, 3 o'clock, 9 o'clock, because sometimes you're doing coronal planes, working in the cavernous triangle, anteromedial, anterolateral, posteromedial, posterolateral, etc. So you need to change the direction of the bipolar insights.
These forceps facilitate access to the coagulation site. The angled nasal scissors are used in the removal of synechia between the nasal septum and turbinates.
Also, there are special now turbinate scissors, because if you are using the Pittsburgh group principle, or also what Dr. Janki Ram teaches, that they follow the principle of cavity and a half. So on the right nasal cavity, they do a partial middle turbinectomy and knock off the 2/3 of the middle turbinate. And that type of turbinate scissors is very helpful to do
Or
this.
for resection of a middle turbinate. The Freer-Joseph double-ended elevator is used to lateralize the middle turbinates, separate mucosa
Also, while taking your Hadad flap, these elevators are very good.
from bone and perforate the posterior septum.
You'll find that some instruments are short length. They are 11 centimeters, then some are 15 centimeters, some are even 17 and going up to 20. The reason is, when you are working in the nasal cavity, you are working on turbinate, you don't need so long instrument. After you cross turbinates, you are coming in the sphenoid cavity, then you need little longer instrument to make you more comfortable. Then you have to do your dural work, and sometimes you have a pituitary macroadenoma with a high suprasellar extension, which is fibrous in nature. It is going almost up to the ventricle. Even if you do a Valsalva, it does not descend down, even if you open your cellar floor and you try to curate it down. So in those cases, you will have to combine many approaches. That means you have to do a transcellular approach, you have to do a transtubicular approach, you have to do a transplanar approach, and also you have to drill the MOCR, the medial optocarotid recess, which is nothing but the lateral most extent of tuberculum sale, otherwise called tubercular strut, on which the snowman, the dumbbell-shaped pituitary macroadenoma is sitting. And after you drill the MOCR, the medial optocarotid recess, only then the suprasellar component descend down. So for these type of cases, a proper instrumentation has been designed.
Straight or upturned, blunt or cutting Blakesley nasal forceps are used to remove fragments of mucosa or...
Now, some are through-cut punch forceps, and when you shear bone, you're trying to cut the rostrum of the sphenoid sinus, the sphenoid lead, it gives you a sound tactile feedback that yes, you have cut. So that feel for a surgeon is very important in an endonasal skull-based surgery, and those instruments have been designed and they are called Silcard. It's a very high hardened steel, a 450 alloy steel with a nickel chrome plating, molybdenum coating put there, and then annealing and hardening is done. So that gives the tensile strength to even cut the rostrum of the sphenoid sinus and giving you the tactile feedback. This is one of the forceps.
The backward cutting punch is...
Now, this is a very good forceps. When a surgeon is doing a two-nostril, four-handed technique, you need to do a posterior hemiceptectomy at the junction of the bony cartilage junction to remove the posterior part of the nasal septum so that you get a big sphenoid cavity to work. And this is atraumatic here. And you engage the posterior the nasal septal wall and you use it, and it's called a backbiter or the Ostom punch forceps, very popular among ENT. And you can do a posterior nasal septectomy followed by a wide bilateral sphenoidotomy and continue a surgery.
Used for partial resection of the septum. The Stamberger circular cutting punch with atraumatic tip.
This is also called popularly mushroom punch forceps. This was devised by Professor Hans Stamberger. Unfortunately, he expired last year. A great pioneer in this field, and this is also safe, and it was used by many surgeons to open or enlarge the sella floor. And now the techniques have revised. Opening is now they make a U-shaped opening on the sella floor
Is also used.
of the dura.
Stationary or rotatable antrum punches are used to open and remove the anterior wall of the...
Now, the new Kassam's Kerrison punches, if you see, we have actually reduced the foot end, because once you drill the sella floor or the tuberculum sale or the planum sundale, then the Kerrison punch has to be used like an elevator. This was popularized by Professor Danny Pradello, now working in Ohio University of US, that it should not be used as a punch, because after this video I'll be showing you some carotid injuries, and you'll find that a very thick foot punch going too deep inside can even cause for trauma. So this has been thinned out so that it is used as an elevator after you eggshell thin, and usually the sella floor is thinned out if there is a big pressure of the pituitary macroadenoma coming in there.
Sphenoid sinus and the sella floor. Round and diamond burrs are used to remove bone in the region of the posterior nasal septum, the sphenoid sinus, and the sella turcica.
3 mm, 4 mm coarse diamond and diamond burrs are good enough. They are also called hybrid burrs to work on the carotid canal and also on the rostrum of the sphenoid sinus, sphenoidal keel. Now this is a dual light.
Pointed or sickle-shaped microblades allow atraumatic introduction for performing incisions in the dura mater and...
So you go atraumatic absolutely till you reach dura. After you press the knob, the knife comes back, and then you can make either X-shape incision. This is the old technique, now a U-shape opening which is being followed, and then the dural work can be done with this knife.
Pituitary capsule. Straight and curved scissors can be useful during incision of the dura mater and the pituitary capsule.
Now these are scissors.
Straight or curved cutting forceps allow the harvesting of tumor cells for...
You saw one of the scissors, the most important scissor for managing your fibrous pituitary macroadenoma, which neurosurgeons hate. Then you will have to do what is called an extracapsular dissection, because you know the anterior phase of the pituitary gland has two layers, the industrial layer and the meningeal layer, and that Kassam rotatable scissor, which is very sleek, go between these layers, and you can go all around the tumor and do an extracapsular dissection. So that's a 360-degree rotatable scissor, the favorite scissor for most of the skull-based surgeons doing advanced skull-based surgery.
Biopsy. Adenoid curettes with straight shafts are preferable for use in the endoscopic technique. These are available in different sizes and angulations. Special rotatable and distally angled curettes and adenoid curettes are used primarily for tumor resection. The The optional locking mechanism allows the instrument to be fixated in a set position. All the necessary equipment is installed on a mobile equipment trolley. This equipment comprises the following individual devices: a digital endoscopic 3-chip camera.
Now this is an autoclavable. This is, you can see written autoclavable camera head. So if you are using this type of camera head, then obviously that adapter will not be required. But of course, these autoclavable series would be slightly more expensive than the non-autoclavable camera head. So it is also available. You can autoclave the whole camera head with the cable assembly at 134 degrees centigrade, 5 to 8 minutes, 3 atmospheric pressure.
Adjustment, integrated zoom and function buttons on the camera head. It's advisable to use a sterile adapter inserted between the camera head and endoscope lens.
For a precautionary measure, yes, it's good to engage the adapter again.
A flat screen monitor for the endoscopic image. The AIDA system is used for digital.
Now, AIDA stands for Advanced Image Data Archiving System. So you can digitally record your high definition videos directly. You can pass a comment. You can take still picture photographs. You can create a patient database. And at the end of the surgery, you can create your own lecture through this. So this is a software which we also sell. And now we have a high definition AIDA system, because if you are lecturing in some international congresses, you must have a high definition videos to show what best you are doing.
Data management and documentation. This is a standalone all-in-one solution, giving the surgeon a simultaneous overview of all images, the system status and control functions. The latest camera technology in Full HD allows extremely high-resolution image display for even better detail recognition and differentiation of anatomic structures. For removing bony structures, a high-speed drill that can be used with a short and an extra long intranasal.
Now we've devised a new handpiece suggestions that come also from Professor Janaki Ram, which works on a similar principle of the carotid Doppler, which gives you a high tactile feedback. When you're working on the carotid canal, that pitch of sound is high, and when you work on the normal structure like the rostrum, the sphenoid sinus, sphenoidal keel, it gives you a low pitch tactile feedback. So probably next lecture when I do, I'll introduce that also.
Nasal handpiece and different diameter burrs. Monopolar and bipolar work.
So that's the cautery for, it has micro mode. You can select it if you are doing a ventriculoscopy. Now let's see the basics of the anatomy and the technique.
Anatomical studies are now demonstrated on a fresh specimen. First, the vestibule of the nose is examined on both sides. The 0-degree telescope is introduced into the right nasal cavity.
So you actually fix the endoscope at 11 o'clock position as per Professor Janaki Ram, which is the ala, and then you slide the endoscope along with this, so you are not dangling, and the endoscope must give the helicopter the superior view and the instrument follow below this. So your suction tube or the elevator is ahead of the endoscope by 1 to 2 centimeters, approximately 2.5 centimeters, and the endoscope follow your instrument. So instrument is ahead of your endoscope.
Parallel to the nasal floor. The endoscope is advanced between the inferior turbinate and the nasal septum until the choana can be seen deep down. The superior apex of the choana, the tubal elevation, and the nasal pharynx can now be identified. Advancing the endoscope over the apex of the choana brings the attachment of the middle turbinate into view. Along the sphenoethmoid recess, the attachment of the superior turbinate.
So that's the place which we call is SCR, the sphenoethmoid recess, and in front of that you have the natural ostium of the sphenoid sinus, which is here. Sometimes it is covered by a layer of mucosa, so you just go about 1.5 centimeters away above the apex of the choana. You palpate a ball probe called ostium seeker, and you can find your natural ostium of the sphenoid sinus.
Is reached. Medial to it is the ostium of the sphenoid sinus. The ostium is usually located about 1.5 centimeters from the apex of the choana in the direction of the sphenoethmoid recess, and is thus in the upper third of the anterior wall of the sphenoid sinus.
So 1.5 centimeters.
The endoscope is now introduced into the left nasal cavity, which is narrower.
Sometimes you have a deviated nasal septum or a large bony spur at the floor of the nasal septum. You must do a septal correction. You can ask the ENTs joining you. Otherwise, you are having difficulty introducing the instruments. And sometimes you have an inferior turbinate hypertrophy and a concha bullosa. Pneumatization of the anterior end of the middle turbinate is called concha bullosa. So there's hardly any space to move in. So surgeon has to do a partial middle turbinectomy to create that space for your instrument. Otherwise, too much of struggling is there to insert your instruments.
The endoscope is advanced through the middle nasal meatus until the choana is reached.
So inside the choana is the nasopharynx. You can see the eustachian tube opening, the tubal eminence, and the fossa of Rosenmuller. So these are structures you can see in the nasopharynx. And this is called the parking lot. So when you harvest a Hadad flap, which is based on the posterior septal artery, a branch of the sphenopalatine artery, the Hadad flap has to be parked here in case of any skull base doing in a sagittal plane like pituitary, etc. But if you do a clival chordoma, then it is not possible to park the Hadad flap in the nasopharynx. You will have to do a middle meatal antrostomy, open the maxillary sinus, and park your Hadad flap, the nasal vascular septal flap, in the maxillary sinus.
Following the apex of the choana between the middle turbinate and the nasal septum via the sphenoethmoid recess, you arrive again at the ostium to the sphenoid sinus, medial to the attachment of the superior turbinate. If you now retract the endoscope and insert it laterally to the middle turbinate, which is carefully medialized, the uncinate process and in the upper part the semilunar hiatus can be identified. Retraction of the endoscope is followed by the sphenoidal phase of the operation, with widening of the ostium of the sphenoid sinus. For this, an antrum punch is introduced, and the ostium is first widened medially, then laterally and caudally. Now the endoscope can be introduced through the widened ostium and into the sphenoid sinus. The endoscope and antrum punch are then advanced through the right nostril. The ostium of the sphenoid sinus is widened as already described. The right sphenoid sinus is now viewed. The endoscope is retracted and reinserted in the left nostril. A sharp Freer double-ended elevator is used to perforate the posterior nasal septum. The nasal mucosa is then reflected from the septum. Blakesley sphenoid forceps are used to partially remove the posterior osseous nasal septum. As soon as the septum is free of mucosa, the round burr can be used. The posterior septum and the sphenoid rostrum are milled off completely. The sickle-shaped microblade is used to incise the contralateral mucosa. Joining the two openings in the sphenoid sinus now allows the surgeon to dissect binasally. The endoscope is positioned in the right and the antrum punch in the left nasal cavity.
So this is a through-cut punch forceps. We are doing a posterior mastectomy now.
With the antrum punch and round burrs, the access is then widened until a broad view of the sphenoid sinus is possible from both sides. Intrasphenoidally, the septum is relatively narrow, slanting to the right paramedially. It's milled off stepwise using the diamond burr. The mucosa over the rear wall of the sphenoid sinus is reflected off and removed using the grasping forceps.
Many times you are working with ENT surgeons as a co-partner in the skull-base surgery. They like to preserve mucosa, which is okay. But in skull-base surgery, you have to take out the mucosa. Why? Because once you put your nasal vascularized septal flap, the Haddad flap, it has to be put on the raw bone. Putting a Haddad flap over the mucosa, mucosa over mucosa causes mucocele. So one has to put in the raw bone, and if this is your defect, which is like 10 centimeter by 10 centimeter, you will have to harvest a dart flap which is at least 25 to 30% more than the carpet area which you are trying to close. So this is very important.
Once the sellar floor has been identified, a central opening is cut in it with the diamond burr. From this point on, the sellar floor is opened up in both directions up to the osseous protrusions of the internal carotid artery. The sellar floor is now completely open, and the dura mater covering the pituitary gland is visible. With the diamond burr and the antrum punch, first the tuberculum.
Now, as you keep moving more deep, your length of the instruments which we supply become more longer.
Selli and then the planum sphenoidale are removed. The view is of the dura mater covered pituitary gland and the internal carotid artery on the right. Above the pituitary gland, there is dura mater above the suprasellar system. To the left are various intracavernous segments of the internal carotid artery, C3, C4, and C5, and craniolateral to these is the opticocarotid recess. The dura mater is incised suprasellarly using the retractable blade.
This is a dural knife.
And then the arachnoid is opened. The posterior surface of the optic chiasm is now visible.
Now that's the optic chiasma. We are now trying to work in the infrachiasmatic area.
The angled dissector is used to reflect the dura.
So this is a very good instrument. It's called the Rosen's elevator. It is available in different sizes to work on the arachnoid and down the tissue.
Further cranially and to open the suprachiasmatic system. The A2 segment of the left anterior cerebral artery can now be seen.
So A1, A2 and anterior communicating artery can be seen pretty well. Sometimes, you know, it's the brain is very supple, so it's very hard to get a suprachiasmatic area open up in some of the cadavers. So this was in a nutshell. I have more long videos. So let me know, Dr. John, is people still active? They want me to continue and they are enjoying, or do you feel it's time to wind up?
Yes,
I can.
I think it's about time to wind it up for this session, Sunil, and maybe ask some questions first before. But first, I'd like them to meet you all. Devi, could you please introduce yourself to Sunil? Devi, could you please introduce yourself? Go ahead, Devi. Go ahead, Devi. Oh.
Hello, can you hear me?
Yes, we can hear you now.
Yes, yes. I'm Dr. Sashank. I'm a neurosurgeon from New Delhi. So I'm working in Manipal hospitals. It is a very good video, a very good
Okay, so
presentation.
hold on, Devi. Hold on, Devi. We're meeting everyone first. We'll turn it over for questions later. Manuel, could you please introduce yourself?
Hello, everyone. My name is Manuel. I am from Dominican Republic. Right now, I'm in Moscow. I am resident of first year neurosurgery.
Welcome. We have another Russian panelist we'll meet too. Hello, O. How are you? Go ahead, O.
Wait, Dr. John.
Go ahead.
Hello.
Yes, could you please introduce yourself?
I heard you.
Okay.
Thank you.
Well, where are you from?
I am in Morocco, for Morocco.
Okay, and what do you do?
I am neurosurgeon. I am neurosurgeon in South of Morocco.
Okay, welcome.
Thank you, John.
Young Hong.
I am neurosurgeon.
Hold on. Young Hong, we're meeting everybody first. Go ahead, Young Hong.
Yes.
Go ahead, say hello to Sunil.
Yeah.
Hello, Sunil. Hello, Sunil.
Yeah. Hello.
Yeah, Young Hong is a neurosurgeon from Zhenghao, right, Young Hong?
Welcome, sir. Welcome.
你好. Hi, I'm your surgery. Today is my duty, so I'm in my office.
Okay, yeah, he's in China. Okay, Edmundo, can you hear me? Okay, Edmundo. I don't know if Edmundo is there.
Hello. Yeah, I'm here. You.
Go ahead, Edmundo. Please introduce yourself.
Yeah, I'm a resident of neurosurgery in Russia. I'm from Peru.
Okay, and he knows Manuel. Está amigos. Los dos Latinos in Moscow. Ulrich, could you please introduce yourself? Are you there, Ulrich? Maybe not. Okay, any comments or questions for Sunil, please?
Yes. I have
Go ahead, Manuel.
For example, thank you for the class. Very interesting. I have a lot of friends in Dominicana and would like to see the classes because they are very interesting. And the products are very modern products. So my question is, you said in the beginning about the different training course, because I would like to take a training in the endoscopic spinal approach. Because, for example, in my country, spinal approach by endoscopy is known very often. If you can send the information about the different conference you show in the beginning, please.
Yeah, I will. You can send me your email at my email ID. I'll show you at the beginning of my lecture on my name tag. And we do huge number of cadaver dissection training program depending on the topic. We teach interlaminar lumbar canal stenosis, transforaminal root, anterior approach, cervical, posterior phrenotomy. You think we have it. So there's good to come and do hands-on cadaver. Plus, we also offer hospitations where you can go to surgeons OR for a longer duration. So kindly send me a mail with your request, and I can send you. We do a huge number of courses. Thank you for your question.
Your mail, how I can get it?
I will share my screen. Just hold on. I'm coming to the main screen. Where is my email ID? Can you see my email ID? Sunil.Verma, sunil.verma @carlstores.in. I'm an engineer. I work for Carl Stores for past 20 years, and I'm in charge for about 18 countries of Asia.
Yeah, I'll make sure that everyone has your email address, Sunil, after. Okay, Manuel? I'll make sure you get his email address. And also, I'll be involved in televising those endoscopic conferences in Peru, Manuel. And we can talk about that also. We can start arranging. And if you feel there's a need for endoscopy in Peru, some courses, we can do that.
In Dominican, for example, I meet I don't know if you know the Professor Capabianca in Italy. I take a training with him.
Yeah, Professor Cavallo is with him.
Yes, of course. I meet Prof. Cavallo also.
Yeah.
They call the tree of Naples. Cavallo, Capabianca, and the other, I forgot his name. It's a younger one.
Yeah, sir, it's very important to do as many cadaver dissection training programs as you can do. This is what Janaki Ram tells. The more you do, yeah, because there is no non-animated skull-based model which can actually replicate a human cadaver brain, and you can have that thing. But before you go to cadaver hall, your endoscopic perspective of the anatomy should be like a prayer. It should be just in your frontal lobe and hippocampus. You should not search for structure, whether this is a lateral optocarotid recess or a supraoptic recess, and what is a maxillary strut or optic strut, the lateral recess, median, V2, etc. It should be like a prayer in your mind, and then you practice on the cadaver, drill out both the carotids and expose carotid and get more and more deep into the anatomy.
Yes, you're right.
Okay, more comments and questions. The other Sunil, you have questions or comments for? Go ahead, Sunil. Do you have any questions or comments for the other Sunil?
Well, it's very nice presentation, and I really enjoyed. But like maybe, like after finishing my study, maybe like I'll come for like practicing of such courses like you are available. If there is a course available, then hopefully in the future I'll join the course.
You are from New Delhi, I believe.
No. I'm from Nepal, but right now, like I'm in China.
He's from Nepal and China, in northern China, correct?
Yeah, but I know Bangladesh also. I stayed Bangladesh for 7 years.
Okay, fantastic. Good to have you on the panel.
Okay, any more comments, questions? Say it now, you got them here.
Yeah, I mean, if you are still interested, I can go on. I have a lot of stuff to share, but I think people have been listening.
Okay, let's see, before we go on, let's see if we have any comments and questions. Muhammad Shafi, Edmundo. Any comments? Hello? Yeah, who's talking? Yes. Go ahead.
Hello?
Yes, hello.
Hello, this is Dr. Dev Shashank from New Delhi. Actually, a good presentation for Sunil Verma. Just to mention that I'm going to pass a mail. Actually, I noted down the mail ID of yours. And maybe in the, I hope you will keep us updated regarding the further cadaveric dissections all over India and the overseas. So it's a very good presentation. Congratulations.
Sir, you are my neighbor. Don't worry. I live in Greater Kailash. I'm from New Delhi. So let's catch up for a coffee. Don't worry. I'm your
Thank
neighbor.
you. I'm going to text you now. Then I have your phone number. So I'm going to text you.
Yeah. So we have huge programs. Janaki Ram is coming up in June. You can join in there. We do more courses with Depojari at Stein Hospital. So many courses are there. Don't worry. India has a huge collection of courses. Don't worry.
Yes. Thank you so much. Fine.
I hope you enjoyed the session.
Okay, more comments? Go ahead.
Hello.
Go ahead.
Hello, I'm Dr. Mohammed Shafi. I'm a neurosurgery resident. Can you hear me, John?
Yes, we can hear you, Mohammed.
I'm a neurosurgery resident in Afghanistan. Thank you very much, John, for organizing such a conference, and Dr. Dear Sunil for such a great presentation. Actually, although I was late, I was on the way, but although it was so interesting, and I'm seeing myself as in the future to go in a neuroendoscopy. So I will email Dr. Sunil and get his detail for training courses. Can you just say, or you will email it, how much it will cost for us.
Sorry, you want my email ID?
Yeah, I got it.
Yeah, Sunil.
Yeah, I got.
Okay.
Okay, I got it. I will email you regarding the training courses.
Yeah. Many
Thank you very much.
Okay, you know, I'm going to put your email address on the screen, big. Can you write it in the chat box there, Sunil? You know, you see the chat box, just write your email there so everyone will get it.
If they can see my presentation, I just directly put my
Yeah,
full slide.
okay. Yeah, I saw it, but I thought you could just type it there to make it easier.
So
Okay,
it is
Sunil,
.in or .com.
Okay, Sunil.Verma
@calsos.in.
Okay.
And also @calso.com. Both come to me. So I have two email ID, .in and .com. So .in is connected with the India server and .com is in Singapore.
Okay, very good.
So I have two offices, Singapore and New Delhi.
Okay.
Now I'm in Cambodia. Right now in Cambodia now.
Okay, that's temporarily for a month or two. Have you met Phil Vanta? He's a neurosurgeon that sometimes participates in these. He's from Cambodia. He's from the capital there.
Calmente Hospital.
Okay.
Yeah. They were there. We had a big program 2 days back on cervical spine.
Hello.
Okay, go ahead.
Hello.
Yes, we can hear. Go ahead.
You hear me?
Yes.
I am Omlal from Morocco.
Morocco. Go ahead, Morocco.
Thank you, John, for this work. I want my question about the CSF like about after surgery. If you have un CSF, une brèche au niveau de la dure-mère, what are you doing for this problem? You understand me?
Yeah. That's a very good question. You see, if you are doing a skull-based surgery to avoid any CSF leak, you must go for a vascularized septal flap. Now, earlier people have been using a random flap like fascia lata, mucopericordium flap. Please understand, these flaps gives jump start to vascularization on the 8th day of the surgery and during the first week post-operatively. In case the patient has a CSF leak, he can deteriorate to meningitis and further deterioration. So nowadays, people are using a workhorse, which is called a Hadad flap or a nasal septal flap, which is based on the posterior nasal septal artery, which is a branch of the sphenopalatine artery. I have a video to show how the flap is harvested prior to the surgery. Otherwise, once you do a posterior hemistectomy followed by a wide bilateral sphenoidotomy, the pedicle is gone and then you cannot have a vasculate flap. Now, this flap can actually cover up to 2 modules. You can have an extended Hadad flap right from the planum stundale to the tuberculum to the sella floor, or from the sella floor down up to the clivus foramen magnum. So to harvest this flap, there are 2 incisions. One is done at the level of the apex of the choana and the other is done at the level of the sphenoid ostium. So inferior incision is at the apex of the choana and the superior incision is at the sphenoid ostium. So when you try to harvest and keep coming down at the superior ostium, you must keep that distance. The height should be 1.5 centimeters below the skull base or below the cripiform plate in order to avoid trauma to the olfactory epithelium. Otherwise, the smell is lost. Actually, I was planning to take the skull base reconstruction, CSF rhinorrhea, especially talking about the Stenberg canal leak, which is called the lateral sphenoidal leak, where you have to expose the lateral recess between the VD1 and the V2. Because today was my first lecture, it was more on care, maintenance, etc. Otherwise, if you are ready, I can cover this in great detail and also tell you if it is a redo surgery, if there is no Hadad flap, you can even harvest a pericranial flap, which is a very big flap from the Marcos window, or you can harvest a inferior turbinate flap. There are many flaps. I have a full package on skull-based reconstruction talk. So this is a nutshell, because I've been also asked by Dr. John to wind up, and probably in the frequent course, speak to Dr. I.P. Cherian. I'm going to cover skull-based in detail, the sagittal coronal with skull-based reconstruction technique. And if you are doing a craniopharyngioma in the endopendicular fossa, there is a high chances of high flow leak. Then just by putting a Haddad flap will not help. We'll have to do a 4-layer of closure. What we call is a half dumbbell fat technique. So the fat is first put half inside the corridor which you have opened and half outside. Then we put a Duragen, then Surgicel, then a Haddad, then a Myroseal, and then you put a Foley's catheter for giving a compression for a period of almost 1 week, ensuring that too much pressure is not given on optic chiasma, otherwise it leads to temporary blindness. So I have a full package of videos on that. If you are still interested, I can continue, but it's all up to you whether you want me to wind
Well, I
up
think
now.
we'll wrap it up today, Sunil, because you gave out so much information. I'm sure everyone enjoyed that, but we definitely will work. We'll do more whenever you're ready. And I'd like to start them in Spanish also for Manuel and Peru, and I'll talk to Manuel about that after we end, about setting up an online conference in Spanish for Peru. So I'd like to thank all you guys for coming. We're moving forward and integrating this platform for education and to spread the knowledge and technology about how to use the tools of neurosurgery, because as every neurosurgeon knows, a good neurosurgeon has to know his tools well. And I appreciate Sunil for coming. So I'm going to end this broadcast and stick around, please. Okay.
Thank you.